Okay. Good morning, everyone. So today, as it was demanded by many of the students that we need to do the CNS,
Good
basically
morning.
stroke and other management, we shall start today with CNS part. So as everyone is aware of our team, this is our team. And before wasting further time, let us move on for the first question. Now, before getting on for the first question, let me just tell you a bit about the regions of the brain because this is a basic thing that we need to understand today. It will be very helpful while solving the questions. Now, this is a diagram which shows all the internal structures in the brain and the functions of it. Just take 10 to 20 seconds, go through this diagram well. Check the regions, check where is amygdala, where is basal ganglia, where is corpus callosum, because these terminologies I'll be using ahead and I don't want any confusions between your mind. So just take 10 to 20 seconds and go through this diagram, please. Okay. So this is the internal structure of the brain, and what all you see here is the basically the frontal lobe. This portion is going to be the frontal lobe. This is the parietal region, the occipital, the temporal, which will be here. Then, which will be responsible for the memory, hearing, emotions, basal ganglia, hippocampus. This is your cerebellum. Also, there will be the pons, the midbrain, and the medulla oblongata, where this one part is located. This is going to be your medulla oblongata. Also, there is this that you get in different parts of the brain region. So if it is corpus callosum, just have a look and imagine immediately there is a case of multiple sclerosis. It has to be located in the corpus callosum, the defect. Then, if it is a thalamus, then it has to be the thalamic pain syndrome. If it is hypothalamus, any of the hormonal disorders, like in the last lecture we had seen, what are the hormones released by the hypothalamus? Okay. Also, there will be the midbrain. The midbrain is going to have you the supranuclear or the nuclear pulses. If the lesion is in the basal ganglia, it has to be somewhere related to the movement regulation or your motor syndromes. Occipital lobe, it is going to be due to the stroke, something related to the vision, there will be the occipital lobe involvement. When we talk about the parietal lobe, there has to be the sensory or the spatial awareness. That is, if there is a complaint that the patient cannot sit on a chair, he falls during sitting on the chair, or he falls repeatedly from the bed. So what has to be the problem where? It has to be in the parietal lobe because the spatial awareness is gone in that patient. Coming to the pituitary tumors, obviously the microadenoma or macroadenoma, it is going to cause you central pontine myelinosis. Basal ganglia, as everyone knows, last time we had discussed the substantia nigra, Parkinson's disease, or maybe some type of dystonia, tremors. And if it has to be in the pons, it has to be myelinosis. Now, before the delay, let us move on for this question. The first question says a 72-year-old man presents with progressive headache, confusion, gait instability over 3 weeks. He had a minor head injury 1 month ago. He is on warfarin for atrial fibrillation. CT scan of the brain shows a crescent shaped hyperdense collection over the cerebral hemisphere crossing the suture lines. What is the most likely diagnosis? Epidural hematoma, subarachnoid hemorrhage, subdural hematoma, or intracerebral hemorrhage? Please post your answers within 5 seconds, everyone. Carefully pay attention to the keywords or the buzzwords. First, pay attention that the man is 72-year-old and there is progressive headache, there's confusion, there's gait instability, so therefore there is motor symptoms as well. And there is a history of minor head injury 1 month ago. So it can be your chronic or a subacute type. He is already on warfarin, that is already on anticoagulants. And the CT scan, what does it show? It shows a crescent shape hyperdense collection. And the cerebral hemispheres that is going to cross the suture lines. So, with all these keywords, what will be the answer? I'm not getting any answers. Yes, what do you think will be the answer? Dr. Ganiat is saying it's D, intracerebral hemorrhage.
Ma'am, I would exclude subarachnoid hemorrhage as it's a sudden onset headache.
Okay.
And epidural hematoma also I would exclude as it has lucid interval and those things.
Okay.
And I'm going with D answer, intracerebral hemorrhage.
Okay, so your answer, Dr. Mifra, is D. Okay. Yes, please give me everyone, give me your inputs. There's no active participation today. 20 of us. Okay. So, any one more answer I'm getting? Dr. Zulekha is saying D. Kavita is saying C. Okay. So let us see what is the correct answer. As I told you, what all the key points that we are saying? Aged man, that is an elderly person who had 1 month before had history of fall. Then the lesion on the CT scan that is going to cross the suture lines. These three are the main thing findings that you see here. If all these are the findings, then it has to be your subdural hematoma and not your intracerebral hemorrhage. Why this is subdural hematoma? Because as you see that it is an elderly patient, then there is a history of head trauma, but it is a like a mild one or a minor one. Basically, they give the history of like slipping from the bathroom floor or a minor fall. The fall in the elderly is very common. Okay, so any history of fall in the elderly with a lesion which is crossing the suture lines on CT scan, close your eyes and write the answer, subdural hematoma. This is the main reason that I have taken up this question for today. So let us see the explanation. Now, it is a gradual onset of the headache over weeks. Crescent shape crossing the sutures. These all are leading to chronic subdural hematoma. Now, how does this subdural hematoma occurs? Basically, any hematoma is going to be due to the rupture or the tearing of any blood vessels. So, rupture of blood vessel is going to cause you hematoma, right? So this hematoma, whenever we talk about this, there is going to be the bridging of the veins, that is tearing of the bridging of the veins. Now, what will be the main cause for this? Hypertension will be the first foremost cause. Then there will be trauma. Okay, so whenever the pressure in the brain region that is into your cerebral circulation that goes high, the pressure into cerebral veins or arteries, it goes high, they are likely to rupture and they are likely to cause you hematoma. And what is going to add up on that? It is going to be the history of minor trauma which is going to add on that. So therefore this is going to cause you slow bleeding which is going to occur over weeks or to months, and therefore we call it as a subdural hematoma. Now, why we were not saying that it was epidural hematoma or subarachnoid hemorrhage or intracerebral hemorrhage? The reason is why, see, if it was an epidural, the lesion would have been a biconcave and biconvex, and it should not be crossing the sutures. As I stressed on this line, that the lesion is crossing the suture is always subdural hematoma, and the lesion which is not crossing the suture has to be your epidural hematoma. Also, there is going to be a lucid interval, which is going to be very common finding, and there is a arterial damage in case of epidural hematoma. If it is subdural, it has to be venous damage. If it is arterial, it has to be epidural. Okay. Now, coming to the subarachnoid hemorrhage. What is it? It is going to be the thunderclap headache, or the worst headache of the life is going to be in the subarachnoid hemorrhage. But here, the patient, he is going to be lying with the headache since past 3 weeks. So there is no specific type of uncontrollable headache that we see. Also, there is going to be blood in the basal cisternae and no crescent shape collection. So therefore, then it is going to be subarachnoid hemorrhage. And intracerebral, why it is wrong? Because there is going to be bleeding within the brain parenchyma and there is no crescent shape collection. So basically, whenever you think of any chronic subdural hematoma, always remember there is a history of fall in the elderly. First, most probably they'll give you that the patient is already on anticoagulant, just like warfarin. Third, the lesion, it is going to cross the suture line. So this is the basic thing that you have to remember about subdural hematoma. Now let us see about other types of hemorrhages, or basically what are the total intracranial hemorrhages. Okay. So basically, this is the diagram which is going to show us all the intracranial hemorrhages. And keep in mind, this is a very important cheat sheet that you have in front of you. The reason being, there are multiple questions which look similar, but then when we come to the final answer, we are likely to get confused. So just keep in mind whatever we are going to learn in the 5 to 10 minutes next. First, if you're talking about a epidural hematoma, the word says epidural. That means what? It is going to be below or above. Can anyone tell me whether it is going to be below your dura mater or it is going to be above your dura mater? Where? What is the meaning of epidural?
Above.
ma'am.
Yes, where?
Above.
Above. Okay.
Ma'am, above.
Yes,
Above.
anyone else?
It's about the dura mater.
Okay, above the dura mater. Okay, fine. So whenever we are talking about epidural, it generally involves between the skull and the dura mater. Okay, so basically it is going to be above the dura mater. The bleeding is between the skull and the dura mater, and it is going to be a lens-shaped bleed. Look at this. Look at this area. It is a proper lens-shaped bleed. This is going to be there, and it is going to be above your dura mater and between the skull cavity. So this is going to be your epidural hematoma. On the CT scan, you see this. There is no crossing over from the suture line. And the most common artery to be damaged here is going to be the middle meningeal artery. Generally, even they ask you as a one-liner, if the patient has epidural hematoma, the most likely blood vessel to be damaged, it is going to be the middle meningeal artery. And if there is going to be the management, it has to be with the help of your neurosurgery. Maybe the burr hole or any other type of neurosurgery we are going to have, but surgery is the main type of management for your epidural hematoma. Now coming to the subdural hematoma, that is your SDH, the bleeding is going to be between the dura. Okay, so now see this, it is going to be below, it is much more deeper, and there has to be a crescent shaped lesion on the CT scan. Also, it is going to cross the suture line. This is going to cross the suture line, the midline. Basically, this region, it is going to cross the suture line, and there is going to be the case of reverse anticoagulation. So, patient is already going to be on warfarin or anything, and then we have to do the reverse anticoagulation. Also, we have to again consider for a burr hole or craniotomy. What is the most common reason out here for the SDH? That is your ruptured aneurysm. Coming for the subarachnoid hemorrhage, that is the worst headache type, where what we see the diffuse blood in the arachnoid spaces. So what is the like you say, the coverings of the brain? If you have to talk, it is going to be P, A, and D. D is for your dura mater. This is
Dura
your
mater.
arachnoid,
Arachnoid.
and this is your pia mater. So which is the closest to the brain? P, A, D. Is P closest or is D closest? Where will be skull? Skull will be here.
Ma'am, D.
Yes. And there will be the brain. What is it exactly? Where is it? Have I written it right?
Yes, ma'am.
Okay.
I think
So,
you read.
yes, someone is saying something on the message. Okay. Dr. Ganiyat, yes. The closest to the brain is going to be your pia mater. The outside most is going to be the dura mater. And after dura mater, you will find the skull cavity. Okay. So, coming to the subarachnoid hemorrhage, there is going to be bleeding into the subarachnoid space. Here, it is going down deeper here. Then that is basically due to the ruptured aneurysm type of appearance. You will see tree-like appearance. And the main vessel to get ruptured here is your basilar artery. Basilar artery you will see in your circle of Willis. I have the diagram ahead. I'll show that to you. So basically, whenever the basilar artery is getting ruptured, then this is a neurosurgery will be the main treatment of choice, but it is always going to be your subarachnoid hemorrhage. These days, there are a lot of questions that they say that a chiro practitioner, a patient is going, he's trying to do some physiotherapy, he's going to try to some do like the alternative medicine. Chiro practitioners, they are most likely to rupture all these blood vessels with the incorrect management of the patient. So keep this in mind. And intracerebral hemorrhage. During the intracerebral hemorrhage, what is happening? This is inside the cerebellum. See here, it is going to be a hyperdense region, which is much more deeper and much more inside. And the most likely artery to be here ruptured is posterior inferior cerebellar artery. So posterior inferior cerebellar artery, that is your intracranial hemorrhage. Okay. Now the line of management here is going to be the control of the BP, because hypertension is most likely in the intracerebral hemorrhage, and neurosurgery if required as and when. Okay, so as we were talking, see here, the pia mater. That is going to be the closest to the brain. The most inside, the most closest is going to be your pia mater, the most inside most layer. And the dura mater is the most outside layer. Why am I stressing on these basic concepts? Once you understand where is the dura, where is the pia, where is the arachnoid, and any type of hemorrhage comes, immediately you are ready to go for the answer. Okay, so dura mater is where it is the outermost layer, this region. Then your arachnoid mater, it is a bit in between. This fenestrous regions that you see, this is your arachnoid mater. Now, when we talk about epidural hematoma, it has to be above. See here. It has to be in the above region near your dura mater. Okay, this is your epidural hematoma. Then we talk about subarachnoid hemorrhage. It is the layer between below the arachnoid and the pia mater. This is your subarachnoid region. Then we talk about intracerebral hemorrhage, which is way more deeper into the cerebellar cortex. Okay, so this is going to be in the cortical region. That is in the central part, maybe the internal capsule, maybe the amygdala region. These all regions, the frontal lobe, parietal lobe, these all are going to get affected when it is a intracerebral hemorrhage. And if it is a subdural hematoma, it is going to be below the dura mater and between the arachnoid mater. It's not going to touch to a pia mater. It's not going to come inside into the intracerebral hemorrhage. It is always going to be between the dura and the arachnoid mater. Okay, so the superficial most type of hematoma is going to be epidural hematoma, which will be what? Which will be your most superficial. And coming here, this will be your subdural, that is into the second degree. This is a bit deeper. The most inside is going to be your intracerebral hemorrhage, the most inside one. And the subarachnoid matter hemorrhage is going to be, okay, fine, we can say grade it as degree 3. So it is going to be inside the cortex, but not completely inside into the brain. Okay. Yes, now this is a major comparative table between all types of hematomas that is important for your exam. Firstly, whenever we talk about the bleeding site, we have already seen it. The epidural hematoma or the EDH, where is the bleeding? Between the skull and the dura, because it is the most superficial one. Coming to the subdural, now it is second degree, that is into dura and the arachnoid. Then coming on the subarachnoid, it is below, that is subarachnoid space between arachnoid and the pia mater, and intracerebral into the brain parenchyma, that is into the brain tissue proper. Now, the vessels involved, there is going to be the artery, which is going to be the mid-meningeal artery, the veins, the bridging veins for your subdural hematoma. Here, there is going to be the arterial again, but it is going to be Berry's aneurysm, which is the most common cause. That is the worst headache of your life. Also, the small penetrating arteries will be seen in the intracerebral hemorrhage. Now, coming to the common causes. The common cause for epidural hematoma will be the bone fractures, the minor trauma will be for your subdural hematoma. Just like here, we have seen in our case, the fall in the elderly who is already taking anticoagulation. So, as I said, if there is an elderly patient, there is a history of fall over before 2 weeks or before 1 week, and he is already on some anticoagulation, close your eyes and write the answer as subdural hematoma. If they tell you that it is the worst headache of the life and there is ruptured aneurysm, then it is obviously going to be your subarachnoid hemorrhage. Intracerebral hemorrhage, the most common cause is hypertension. Uncontrolled hypertension, basically your hypertensive urgency or hypertensive emergencies. Here we routinely do a CT scan of the brain or a MRI brain, irrespective of the conditions of the patient. So therefore, there will be the hypertension just for checking the intracerebral hemorrhagic lesions. The onset, when we talk about the onsets, it is going to be rapid for the epidural, gradual for the days and weeks, just like in our case, we had 3 weeks. Here, the SAH, that is, it is a worst condition, so therefore it is sudden, it is acute, and ICH is also sudden and acute. So, any type of hemorrhage that they are showing, which is going to take weeks, is always going to be again your SDH. Others, everyone is sudden, acute, rapid. Okay. Then coming to the headache part, headache is going to be severe in your epidural hematoma. It is going to be from mild to moderate into your subdural hematoma. And as we know that the worst headache of life, it is going to be in the SAH. And in intracerebral hemorrhage, see, if it is a diabetic patient and he already has hypertension, he has this intracerebral hemorrhage, maybe that patient is not even going to feel any type of pain. The patient doesn't know whether there is a hemorrhage or not. There won't be any type of pain which will be seen. But in some patients, there can be pain. So the pain factor doesn't really count in the intracerebral hemorrhage part. CT appearance, yes, very important, because in the exam questions they mention biconvex lens-shaped epidural. Crescent shape, that is your moon shape type of a lesion, always is your SDH. Blood in the sulci has to be your subarachnoid hemorrhage. And hyperdense focal bleed, that is your vein parenchyma, intracerebral hemorrhage. Now, what are the risking groups? Young adults, always you see epidural hematoma. For example, if it is a fall from the bike, a biker, he is having a very high speed and he falls off, most likely to get epidural hematoma. But SDH is not common in bikers because it is going to be middle-aged or hypertensive patient, as I already told you, for intracerebral hemorrhage. Then, am I audible to all of you?
Yes, madam.
Okay.
Yes, ma'am.
Yeah.
Yes, ma'am.
Now, there is lucid interval. Sometimes they don't tell you, don't think about the lucid interval, but just think that the patient already has a history of anticoagulants. There is a crescent lesion which is going to cross your suture line. This has to be your subdural hematoma. If it is a thunderclap headache or the worst headache of the life, close your eyes and write subarachnoid hemorrhage. And if there is going to be any hypertensive patient or a diabetic patient, it has to be most probably your intracerebral hemorrhage. Just for example, if they mention the patient's BP is somewhere around 190 by 100, just think of your intracerebral hemorrhage. Immediate management, surgical evacuation, burr hole surgery, and in subarachnoid hemorrhage, you can do a CT scan, lumbar puncture if CT is negative. And the control of the BP plus surgery, plus or minus, depending on the neurosurgeon's call or depending on what is the status of the patient. If there is any neurological deficit, first control the BP, and the BP should not be lowered less than 25%. Sorry, more than 25% whenever you're trying to control the BP in case of intracerebral hemorrhage. So IV BP control should be done. What is the drug of choice for managing the BP as IV? I've already mentioned in the class. How will you manage BP?
Labetalol.
Yes, right. Very
Ma'am.
good. So it has to be
Yes.
IV labetalol or IV esmolol. Okay. So is the hemorrhage part clear for all of you?
Yes, ma'am.
Perfect,
Okay.
ma'am.
Yes. Now, if I give an example, okay, listen to me carefully. There is a 24-year-old man. he was going for a trekking and he suddenly falls on a rock. He has severe headache. On the CT scan, I see a lens-shaped appearance. What will be the type of hemorrhage?
It's epidural type
And
of hemorrhage.
It's
epidural.
Yes.
Epidural.
Okay, perfect. So now I can say that everyone is understood. Now, next example. I'll write it here. It has to be your 54-year-old male patient who is having history of hypertension. Now comes with neurological deficits, and you see brain parenchymal lesion. Okay. So what is the type of hemorrhage?
Intracranial.
intracerebral hemorrhage.
Intracerebral hemorrhage.
Very good. Yes, very good. So it has to be intracerebral hemorrhage.
Hemorrhage.
Perfect. Any confusions in this?
No, ma'am.
No, ma'am. No.
Okay. So one more question if I ask you that if there is a hemorrhage, you see a hemorrhage, you see a crescent shape hemorrhage crossing the midline or crossing the suture line, and the patient has a history of fall 2 weeks ago, what type of hemorrhage will it be?
Subdural. Subdural.
Subdural.
Subdural.
Okay, perfect. Very good. So all the hemorrhages is clear. Now let us move ahead with the next question. A 62-year-old man presents with sudden onset weakness of the right side of the body involving the face, arm, and leg. Examination shows increased tone, exaggerated reflexes, and an extensor plantar response on the right side. Sensory examination is normal. Where is the most likely site of the lesion? Answers: right cervical spinal cord, left internal capsule, right frontal lobe, thoracic spinal cord. Yes, please think on it and try to tell me what answer.
Left internal capsule.
Okay, very good. Can you explain me a bit on this? Can I get your name, please?
Right cervical spinal cord. Option A, right cervical spinal cord and thoracic spinal cord. Sensory involvement is also there. Here,
Okay.
sensory examination is normal.
Hmm.
If right frontal lobe is involved,
Hmm.
there is a weakness on left side. Here is a weakness on right side of the body.
Hmm.
So most probably, uh, answer is from my side is left internal capsule.
Okay, fine. Everyone's saying the answer is left internal capsule on the chat box also. Yes, Dr. Tariq, Dr. Akbar, Dr. Rabia, Dr. Zulekha, Dr. Ganiyat. Okay, fine. So everyone is perfectly right. The answer is left internal capsule. Now let us see why is the answer as the left internal capsule. Before that, I see that the examination is showing you increased tone and exaggerated reflexes, extensor plantar response. So basically, there is going to be exaggeration of reflex and tone is increased. So with these two lines, can anyone tell me whether it is a upper motor neuron lesion or a lower motor neuron lesion?
So,
Upper
ma'am,
motor.
UMN type of lesion, upper motor neuron.
And why? What is the reason that you can say definitely it is upper motor type of lesion?
There is increased tone, increased hyperreflexia.
Okay. And if it is a lower motor neuron lesion, the tone will be decreased or increased?
Decrease.
Decreased. Okay, fine. So basically, if you want to differentiate between upper motor neuron lesion and lower motor neuron lesion, always you have to think about the tone, the reflex. See, this is a simple table. Okay, I'm not just confusing you guys. What's wrong? Okay, fine. So this is upper and this is lower motor neuron. Okay, and I have to write here what? I have to write here tone. there is going to be reflex, and there is going to be plantar. Plantar reflex, basically. Plantar reflex is of extensor and 1 minute. Flexor and extensor type. Also, there has to be one pointer for fasciculation. Okay. So, in upper motor neuron type, the tone is going to be increased. Lower motor neuron tone is decreased. Reflex in upper motor neuron increased. Reflex here is decreased. The plantar is going to be extensor.
Upward.
So if you write, yes, if you write here extensor plus plus, and there is going to be flexor.
Exit.
Flexor has to be negative. Fasciculations are not present here.
Negative is
Fasciculations are going to be present in the lower motor neuron lesions. So this is the basic thing that you will remember. Once you are zeroed down to upper or lower, then you can think of the other things. Now let us move ahead with the specific things. Okay, so the correct answer here is the left internal capsule. Why? Because there is going to be hemiplegia, that is your face, arms, legs is involved on the one side. Upper motor neuron signs, already we saw, that is there is increase in the tone, reflexes, extensor plantars. Sudden onset, vascular cause. So the internal capsule, it already contains what? It contains your corticospinal fibers from the face, arm, leg, which is tightly packed together. So for this, can anyone tell me what type of diagram do we see here? Just give me a minute. Has anyone heard of the homoloncus diagram? I'll just post it here. 1 minute.
No.
No, not
ma'am.
heard? Okay. I'll just put it up. 1 minute. I just forgot to add that. Give me a minute. So this homoloncus diagram, all of you have done your MBBS. It was there in your first year physiology books, which everyone ignores it as a student. Okay. So see this now. What is this? This is
Remember,
a homoloncus diagram. Remember this diagram? Must have seen it somewhere,
ma'am.
but not exactly in detail. You have studied it. This is a very beautiful diagram. Here, what you see, here you see the representation of the body, that is the motor or somatosensory in the brain. So if there is going to be a lesion, for example, if I say, if there is going to be a lesion near your this part, okay, if there is a hemorrhage here, the what is most likely to be damaged? Your knee, ankle, toes, genitals, all this part will lose on its motor control. Now, where in this question that we are seeing that the lesion is going to be where? It is has to be here somewhere. Why? Because the face, the eyelid, the lips, jaw, tongue, everything is affected in our patient. So maybe the vascular lesion has to be here. If it was somewhere that only the foot motor sensations was gone, only the plantar was flexor, it was not extensor, it was only plantar flexor, so the lesion has to be most likely into this central sulcus. Understanding? So this is your central sulcus out here, and this is your region of your cerebral cortex. So this cerebral cortex, this homoloncus, he was a person who said that our brain or our body is represented in such a way on the cerebral cortex that whenever there is a vascular lesion or whenever there is a problem here in the frontal region or into your cerebral cortex, you should always remember where exactly can be the localization. If it is hand, if it is elbow, it is the head and neck, it is the hip, something or that, the motor correlation is always done with the help of homoloncus. Okay. Now, coming on for this, there is a corticospinal fibers for the face, arm, and leg tightly packed together. Therefore, the lesion can be inside your left internal capsule. Okay, so coming to the brain motor type of defects. Now, these, whatever you see here in the list, are all the brain motor type of defects. Now, what are these motor defects? Basically, coming on for your hemiplegia, paraplegia, quadriplegia, they all look similar. And when you're solving the questions, everything comes up togetherly, and then you really don't understand how do I go ahead with it. So, whenever such type of question comes, firstly, concentrate on the specific terms that they have given. Try to differentiate whether it is upper motor or lower motor. If not, then try to differentiate on what type of paralysis is it. Now, let us see each one properly. If we say that it is a hemiplegia, that is, it is half-sided paralysis of one side of the body, that is only right or only left. The distribution of weakness is going to be where face, arm, and leg on the same side. So that is going to be your ipsilateral. That is the same side. It's not that, left-sided face is paralyzed and my right-sided leg is paralyzed. No. In everything, all the lesions or all the weakness has to be on the same side. So, where is the lesion likely to be? It is in the contralateral brain, that is in the internal capsule, or it is in the context, that is of the opposite side. Whatever is the dominant side, the opposite side will be the lesion. So, if the lesion is on the left side, the right side of the brain is most probably affected. Okay. And how is the onset? It is a sudden onset. Generally, in the stroke, we see this. So, for example, if there will be a patient who will be like, after waking up, I had a complete right-sided weakness of my body. My face was deviated to the right side. So, therefore, where will be the lesion on the CT scan? Either it is going to be on the left side or the right side. Which side will be the lesion? Left or right?
Always opposite side.
Yes,
Opposite
so it
side.
is always opposite side, therefore it will be on the left side. Okay. Then coming for paraplegia. Paraplegia means what? Paralysis of the both lower limbs, not the hands. It is always the lower limbs. Paraplegia, always think it is only legs. Both the legs, it is paralyzed. Where is the most likely lesion? At the thoracic spinal cord. And what will be the main clue that you will get? The arms and the face is spared. That the arms, the face, the sensation till his umbilicus is fine. After the umbilicus, everything is gone. What is the reason? The reason is there is a lesion at the thoracic spinal cord. Now, coming to the quadriplegia. Quadriplegia is what? Paralysis of all the four limbs, that is both arms, both legs. Where is the lesion? Cervical spinal cord. And generally, it is having a neck trauma, or you can say a bike accident, or a fall from the first floor of the building, or something like that. So, major trauma, which is going to affect all the paralysis of the four limbs. The lesion has to be at the cervical spinal cord. Lectures that first four more important is your spinal support, basically your cervical spine support that we give to the patients after triage or inside a triage when a disaster management is taking place. Then coming to monoplasia is what it is? Paralysis of only one limb, that is only right side arm or left side arm or one leg or one arm. Okay, here there is going to be the motor cortex which will be involved, and peripheral nerve damage can be here, or it can be localized to single dermatome at times. Okay, so if it is localized to single dermatome and it is never in stroke, very rare, it cannot happen in stroke, it is localized to single dermatome, there is something related to the motor cortex division. Coming to hemiparesis. Paresis means what? Basically, it is partial weakness of one side. Okay, so partial weakness, whenever we call it, we are going to face the weakness of the face, the arms, and the legs, but it is going to be a milder version in case of hemiplegia. So, if you compare hemiplegia or hemiparesis, is what? Hemiparesis is lesser, what you say, severity as compared to hemiplegia. Where is the lesion going to be? The lesion is going to be at the brain, but it is a upper motor type of neuron lesion. Okay. It is paralysis. Paraparesis is what? Partial weakness of both the legs, again, both lower limbs, but the lesion is going to be at the spinal cord, again, a upper motor neuron. So there's a one question in this. If there is a lesion at spinal cord, but we call it as a upper motor neuron lesion, tell me the lesion will be below the medulla oblongata or above the medulla oblongata? Where? I mean,
Ma'am,
before
above
the
the
crossing
medulla
over
oblongata.
or before the after the crossing?
Above.
Yes,
Upper
right.
motor is above the medulla oblongata.
So it has to be above the medulla oblongata. And generally it is seen in myelopathies. Now coming to again LMN and UMN. LMN, weakness due to LMN is the damage. Here there is going to be weakness in the segments, or there is going to be a focal weakness, just like only, only his fingers are weak, only his foot is weak, or only his knee joint is weak. So something which is going to be a segment and focal. The lesion most likely to be is at the anterior horn cells or the dorsal root ganglion. This has to be your lower motor type of lesion. And fasciculations present is only going to be your keyword here. If they say that fasciculations are present, there is what you say loose, that is spasticity is not there. Okay, so there is no spasticity, there is loosening of the flaccidity of the muscles. Immediately think of lower motor neuron lesion. If there is rigidity of the muscles, always think of upper motor neuron type of lesions. Remember? So if it is flaccid, if it is loose, or the muscles have become very much losing their tone, then has to be lower motor neuron. And if the muscles are tight, the patient is into spastic or a rigid position, or maybe you can differential diagnosis, you can get it for tetanus, that the patient is very much into the muscle rigidity. What will be the type of lesion? Upper motor type of lesion. All right. Is all this paraplegia, hemiplegia, monoplegia clear for all of you?
Yes, ma'am.
Okay.
Yes, ma'am.
So now, uh, paralysis and plagia. So if it is hemiparesis and hemiplegia, can anyone tell me what is the difference between that?
Ma'am, in paresis, there is no complete loss of power tone. Sorry, in paresis, there is no complete loss, and pelagia means complete loss of the movement.
Right, right. So paralysis is incomplete and it is lesser severe as compared to plagia. Okay. Now, for example, if I have a question, I'm telling you, like, there is a 63-year-old female whose right lower limb has loss of tone. Then there is going to be fasciculations. What type of lesion is it, or what type? I'll just give you option: hemiparesis,
Ma'am, this
paraplegia,
is lower motor neuron.
okay,
Uh,
or it is monoparesis, or none of the above.
Monoprasis.
Mo-
Really? Please see for
No,
it.
please.
63-year-old female, right lower limb, both. If I say,
Both.
okay, loss of tone, fasciculations.
Ma'am,
Now tell me. I can
ma'am,
confuse you also.
this is the hemiparesis.
No,
Hemiparesis.
Para
no, my dear. It is
Lower motor neuron
monoparesis.
lesion.
monoprasis.
It is monoparesis, lower motor
No
neuron
prices.
lesion.
Yeah.
Yes. The reason
Ma'am,
being, yes, Dr. Rabia, allow me a minute.
loss of both limbs.
No, no.
One
Right
leg.
lower limb. Right lower limb. Only one side.
Now, okay, light lower. I thought you saying loss of both limbs. Okay, then okay,
No, no, no.
monoparesis.
It's right lower limb. Okay. Clear? Okay. If there is, I ask you another question.
Ma'am, yes.
Yeah. One more question. If there is a 48-year-old male, chronic smoker, okay, and he has hypertension, he has loss, no, not loss, I'll say rigidity of one side, full. One side, that is his face, his arms, his legs, everything on the left side is affected. So what is he a case of? Is he a case of hemiplegia? Is it a case of hemiparesis? Is he a case of monoparesis? or none? What?
Motor neuron
Then
Hemiplegia?
hemiplegia.
hemiplegia.
Then hemiplegia.
Very good. Perfect. So I guess everyone's understanding. Any doubts anyone has in
Yes,
this?
ma'am.
Just go through this for 5 seconds and ask me if there are any doubts in this.
Then kindly share these slides.
Yes, I'll do that. Anyone has any doubts in this? All clear about?
Ma'am,
Yes?
hemiparesis and hemiplegia both will
Hmm.
have the site of lesion at the same place, but the effect will be less in paresis and effect will be more in plagia. Is it that so?
See, in hemiparesis, the lesion will only be in the brain. It cannot be in the spinal cord. Both, as you said, that the lesion is going to be in the brain, but on the opposite side. Only one symptom that you are saying is right, कि hemiparesis is lesser severe than hemiplegia. Okay? Is your doubt clear?
And the site of lesion
Same.
both way is same.
Both opposite side.
Okay.
Yeah. Okay, so this is a diagrammatic representation. See, if we are talking about hemiplegia, what is going to be here? It is going to be one-sided. But the lesion is going to be where? The lesion is going to be on the opposite side. Okay? So this is the contralateral lesion here. Then paraplegia, what do you see? Paraplegia, both side, like the both lower limbs, they are having a problem. The lesion, as we said, is going to be in the thoracospinal tract. So this is your thoracospinal region. If it is quadriplegia, where has to be the lesion? Quadriplegia? I don't have the table in front of you. Where has to be the lesion in quadriplegia?
Cervical spinal cord.
Cervical
Okay,
spine.
very good. Quadriplegia, the lesion is at the cervical regions. Monoplegia, single dermatome, as I said, or a nerve root ganglion or a dorsal root ganglion can be there in your monoplegia. Okay. So,
Madam,
all this time, 1 minute, why is this?
Madam,
Yes,
can you just explain the Brown-Sequard syndrome? What is the connection between this plegia and
I'll
Brown-Sequard
explain that
syndrome?
to you. Yes, 1 minute, I'll explain that to you. First, I want to erase this 1 minute. This is not being erased. Okay. Yes. So, my dear, what was your question?
Brown-Sequard syndrome. It's
Okay. So,
sometimes
you
it
want
comes
as an
ipsilateral side
MCQ.
paralysis and contralateral pain and touch losing. So
Okay,
how can
fine.
we go?
See, in Brown-Sequard syndrome is what? Brown-Sequard syndrome is basically the injury of the half-sided part of the spinal cord. Okay. So, as you have integrated this topic, give me a minute. I'll just add up a new slide here. Anyone has any inputs about Brown-Sequard syndrome? Does anyone know about it? Yes,
There's a
please volunteer.
hemisection of the
Spinal cord.
Spinal cord. Okay.
spinal cord,
So,
yes.
yes. So, Brown-Sequard syndrome is basically due to cut lesion of half side of your spinal cord. Okay.
Spinal-
So it is the half-sided injury of the spinal cord. But here it has to be producing your ipsilateral motor lesions and contralateral sensory lesion. So two things you have to remember. Same side motor lesions will be affected and contralateral or contra side, basically opposite side. Opposite side का यहाँ पे sensory affected होगा. Sensory lesions will be affected on the contra side or on the opposite side. ठीक है? Now, why do we say that it is a ipsilateral lower motor neuron weakness, or if it is a segmented type of lower motor neuron weakness? So, if it is the same sided lower motor neuron weakness, it has to also have some sensory loss here. Some sensory loss. That is 10% sensory loss, but 90% motor loss on the same side. Same ways, on the opposite side, sensory lesion will be 90% and motor will be 10%. This is the basic concept of your Brown-Sequard syndrome. Now, if we say that why is there a loss? Why is there a opposite side wala sensory loss? The reason is the pain fibers, they are going to come to the, go up at 1 and 2 segments near your spinal cord, but they are going to have a crossing over. So whenever they are doing a crossing over, there has to be the sensory lesions which are gone, because the sensory fibers, they cross over. Okay. So therefore, the deficit is going to appear which is slightly below the lesion or slightly below. So for example, if the lesion is at T10 and the lesion is at T11, so the sensory loss will be below your T10 to T12. It is never going to be up. The reason being the crossover. And if you talk about what is the diagnosis, what do we see in the diagnosis? There can be a hemisection lesion, there can be a compression, there can be any tumors, or there can be any demyelination of your spinal cord, maybe multiple sclerosis or ankylosing spondylitis. These are the two main causes where you can have the Brown-Sequard syndrome. Or sometimes if during a bike accident, there is going to be a Brown-Sequard syndrome type of lesions that we see. Here we have to do immediate surgery management, and spine immobilization will be the main part. But the main reason is going to be decompress the spine, whatever is causing the compression or whatever is causing the de-alignment or wherever is the injury at the spinal cord, immediately repair it, immediately go ahead with the surgery and then manage it with the medicinal part. Basically, decompression surgery is the surgery of the choice for any lesions of your spinal cord. Okay. Is any more doubts in this?
Yes, ma'am.
Yes.
Ma'am, in spite of accident, which some disease also got this Brown-Sequard syndrome types, Leon?
Yes, as I told you, any type of tumors, any type of degenerative spinal cord lesions, they can cause you this Brown-Sequard syndrome. One is emergency
Like
causes and one
spine
is
TB, like
yes, it
spine
can be
TB,
seen in
POTS.
POTS. Yes, it can be seen in POTS spine. So just let me write it up for you. It can be seen in multiple sclerosis. Okay, because it is one of the degenerative disease. It can be seen in POTS spine or your TB spine. It's one and the same. Also, your cervical disc herniation of the disc, which is a very common finding on the patient MRI that you see. And it can be any tumor of the spinal cord. Maybe it can be a neurofibroma or it can be a meningioma. So these are all the causes of your Brown-Sequard syndrome. And if it is a like you say, sometimes a gunshot wound, sometimes a bike accident, sometimes a penetrating trauma injury, just like a knife injury or a sword injury, anything like that. Clear? Any more doubts?
Clear, ma'am.
Okay, thank you.
Okay. Okay. So now, when we come to localizing the lesion at any of the lobes of your brain, how do we say कि कौन से brain में region में क्या difficulty है? What is it going to be? If it has the lesion on the frontal lobe, what will be the function that will be affected? The voluntary movement, just like if you're asking the patient, lift up your leg and he can lift it up, it has to be fine. The frontal lobe is fine. But if the patient cannot lift up his leg, even after your instructions, the lesion can be at the frontal lobe. So what will be the contralateral effect? Hemiparesis, that is similar weakness, will be there in the opposite side. Sensory, minimal, because 90% motor, as I told you here, and 10% sensory. Also, there will be a personality change and disinhibition. That is, the patient will behave completely different. He can become more aggressive, or he can become very naive, he can become very depressed. So there will also be some emotional and personality changes if the lesion is at the frontal lobe. Then coming to the Broca's area, When we talk about the Broca's area, what will be here? Here, the Broca's area is responsible for the speech production. Now, when I say speech production, that means able to talk. Power will be normal, sensory will be normal, but expressive aphasia or Broca's aphasia will be here. Now, can any difference between Broca's and Wernicke's aphasia? What's Broca's and what's Wernicke's aphasia? Yes,
No idea.
very commonly they ask you. See, Broca's aphasia means what? Here in the Broca's area, the patient can understand, but the patient can sense it, like what is wrong, but the patient cannot speak. That is the speech production. Okay. So basically, the patient cannot talk or the patient cannot express. This is your Broca's area. And in Wernicke's, what is happening? Wernicke's aphasia, here the patient is able to talk, but he talks very weird. That means the patient cannot process what he wants to talk. That is going to be your Wernicke's side. Comprehension is lost, but speech is right. So basically, thinking and comprehension. So thinking and comprehension is lost in Wernicke's. A simple trick to remember your Broca's and your Wernicke's is C. B for Broca's and B for boys. So generally what happens? Boys understand everything, but they are not able to express themselves. Boys never talk much. So therefore, if it is a Broca's aphasia, it has to be what? It has to be your speech production is reduced. He cannot talk, but he can understand everything. Wernicke's, woman. W for Wernicke's, W for woman. What happens generally with women? Women talk a lot. But once they talk, after talking, they'll think, oh, what was I talking? So there is too much of talking that the patient will do, but there is lesser comprehension or lesser thinking or lesser processing. That is your Wernicke's aphasia. Always remember this because this always comes in the exam. And the lesion at Wernicke's is going to be the temporary lesion or you can say temporal lobe. Why? Because woman's thinking or woman's anger is temporary. So it has to be a temporary lesion, a temporal lobe. Broca's area, it has to be in the frontal type. So boys wants to be in the front always. It has to be Broca's aphasia there. Coming to the parietal lobe, there is going to be sensory processing, mild weakness is possible, and contralateral sensations is gone. So parietal lobe, if there is a lesion, majorly the sensory part, if it is gone, always think for the parietal lobe. Coming to occipital, everyone knows it is vision related. Visual field defects will be there. Hemianopia or temporal hemianopia, all these things you will see in the occipital lobe. If the lesion is going to be at internal capsule, what is going to be happening? There is going to be dense contralateral hemiplegia, just like we have seen in our question, left internal capsule lesion. So therefore, it is going to be dense contralateral, opposite side hemiplegia. Basal ganglia, movement modulation, movement disorders, Parkinsonism. So if a patient is having all the symptoms, rigidity, tremors, unstable gait, all Parkinson symptoms, always see that the lesion is at the basal ganglia. Cerebellum, the balance is gone, the coordination is gone. Then you can say the lesion is at cerebellum. Brainstem, there is going to be, if the lesion is at the brainstem, there is going to be crossing over sensory signs. That is, the sensory signs will be disturbed at the brainstem. The sensory signs will be gone on the opposite side. If there is a brainstem lesion on the right side, the sensations on the left side will be gone. Okay. Yes. Now these are the different territories of the brain that it is supplied. So just like circle of Willis, you people can do as your homework and check. This is the circle of Willis. This is the basilar artery. These are all the anterior communicating, the left spinal artery, then the mid cerebral artery. All this is the circle of Willis and all this is the type of affected region. Now I'm not explaining this. We have less time. I'll share you the slides. You can get along with this. So the lesion of infarct and the
Ma'am,
localization.
is it come in the exam circle of Willis hole about the arteries?
Yes, it does come. Sometimes they ask you about one-liner, sometimes they
Oh my
try to
God.
show you such type of image-based question, and then they ask you which artery is involved. So if there is a image like this, you have to say for anterior communicating artery.
Ma'am, it's a GP exam, but very tough.
Okay, so this is again the same thing that I was trying to tell you with a picturistic representation. Yes, now this is a simple part. Coming to what lesion at the spinal cord is going to show you what symptoms. If the lesion is at cervical part of your spinal cord, near your neck, near your cervical vertebrae, what is going to be the effect? Quadriplegia. Sensory, where is it going to go? Loss below the neck. And what will be the exam thing? They are going to try to tell you that the patient is having respiratory failure or the patient is unable to breathe. So if the patient is unable to breathe with quadriplegia, the lesion is going to be there at the cervical cord. If it is the thoracic cord lesion, the patient is going to have paraplegia. That is, both the lower limb strength is gone and the arms are spared. Okay, if the lesion is going to be at lumbar cord, what will you see? You'll see paralysis, paraparesis, and leg sensation lost. Bladder and bowel control is lost. That is, bowel bladder involvement is there. If the lesion is at sacral part, here again bowel bladder and libido sexual capacity that is gone. Early bladder dysfunction is going to be there. Okay. I hope the lesions is clear. See, it is very CNS heavy class today, but this is very important. Any doubts in this?
Clear, ma'am.
Okay. Now, this is localization. That's fine. Now, let's move on for the last topic of today. We have Glasgow Coma Scale. Is everyone well versed with Glasgow Coma Scale?
Yes.
Yes, ma'am.
Okay. So, if it is a 35-year-old man brought to the emergency department after a RTA, on examination, he opens his eyes only to painful stimulus, incomprehensible sounds, withdraws the limbs from the painful stimulus. What is his GCS? Please answer me this question.
Yeah, 8.
Yes, Dr. Piyush, you're saying 8.
Yeah.
Yes, other people, why everyone is so silent today?
9. I think it's 9.
Dr. Abby, Dr. Gania is saying A, 6. Okay.
No, I'm
What is
saying
our
9.
answer, Dr. Abby?
9.
9. Okay. Yes, other answers, please. Just last 10 minutes, bear with me.
8. Answer C.
8. Okay. Fine.
Ma'am,
So let us see
I'm
what
also
is
on
the
8.
Yes. So the answer here is 8. Why the answer here is 8? Whenever any question comes on GCS, always try to calculate just like a maths problem. GCS, we try to calculate on what parameters? Eye opening, verbal response, motor response. So out of 4, out of 5, and out of 6. Okay? Now, what is the question here that the patient was trying to tell? He was trying to tell that there is going to be eye opening, there is going to be motor score 1 minute. Opens two eyes to painful stimulus and makes incomprehensible sounds. So, painful stimulus. So, here it is going to be 2. Now, what are the sounds that he is making? 2. And he withdraws from painful stimulus. So, withdrawal for pain here. So, it has to be 4. Therefore, we get our answer as 8. Why? Because he was trying to eye opening on pain, then making sounds and withdraws from the pain. Okay. So, when we are calculating it, let us see. For example, if there is a 22-year-old man, he fumbles. Okay. Then he opens eyes. Eyes are normal. That means he's spontaneously opening his eyes. Verbal response, he is doing fumbling of the words. Then he localizes pain. He can show with one finger where is it paining exactly. So what is his GCS? Kitna hai batao?
12.
What is his eye score? First tell me what is the eye score? Spontaneously opening eyes. So therefore 4.
4.
Okay. Verbal response, he's fumbling. Fumbling means what? Inappropriate words or inappropriate sounds.
Inappropriate word.
Yes. So he's fumbling. That means the words are going to be this. 3 will be the score here. And he localizes pain. That is going to be 5. So what is the GCS here? 3, 4 and 5.
12.
12.
7 and 5. Right? Okay, next question. In GCS, I know everyone knows GCS, but just for your information, if there is a woman, she is not opening eyes at all. Okay, so the woman is not able to open the eyes. No eye opening. Then no talking. And only extension of all limbs. What is the GCS?
4.
Yes?
4.
Yes, right. Very good.
4.
So the GCS will be 4. Why? Because extension of all limbs means your decerebrate rigidity. If it is a decorticate rigidity, then it is flexion of all the limbs. Now, as there is extension of all the limbs, it is a decerebrate rigidity. So the score here is 2, here is 1, and here is 1. So she is into GCS 4. About GCS, there are only few pointers that you should remember. When I talk about GCS, the eye opening, the verbal and the motor, it is totally going to be out of 15. If the patient is less than 8, do not wait. Intubate, because airway protection is very much needed if any GCS equal to or below 8 is seen. Remember this. Motor score, most important prognostic indicator, and best motor response, it is to be recorded. Because why always we say that the best motor score is very important or it is the best prognostic indicator? Can anyone tell me?
Because cortex is intact.
Very good. Because we can say that the lesion is not at the cortex, but it is only at the sensory pathway. So therefore, motor response is going to be the most better prognostic indicator in case of GCS. Incomprehensible sounds, that is not always equal to your inappropriate words. As I told you, fumbling, or they can use that he is talking, he is calling a bottle, he is not able to recall a bottle, he is not able to recall the words of his daughters or his children or whoever it is. So therefore, always differentiate between incomprehensible sound or incomprehensible word. Immediately there is a difference of 1. Eye opening to pain is always E2, not E3. That is painful stimulus. Eye opening to painful stimulus is always E2. Minimum GCS to call a coma, it is 3. And if it is a severe head injury with a GCS which is less than 8, it has to be given a intubation. Then if it is a moderate GCS, just like 12, we solve one question. You do not need to intubate, but you just need to closely monitor. And if it is a mild GCS compromise, 13 or 14 maybe, that time also monitoring is required. Sedation, alcohol, or intubation can also sometimes give you false GCS scoring. Now, for example, if you see a patient who is highly alcohol intoxicated, comes to you with hematemesis, and maybe he is having Wernicke's encephalopathy also, what will you do? Will you take his GCS or first will you stabilize him? What will be your treatment part, management?
If the patient is conscious, we'll first stabilize him.
Okay, very good. Very right answer, Dr. Abby. That means you have understood GCS properly. So once the patient is stabilized, once he is out of his alcohol abuse or his substance abuse, then you can take his GCS unless until required for the emergency management. Okay. So I guess that was all for today from my end for CNS. I hope everyone has understood this. Any doubts anyone has on type of
Ma'am,
lesions
very
or
well explained.
thank you so much.
Ma'am, very well explained. Well.
Yes, I'm glad everyone understood that. Please, you are
Thank you,
free to
ma'am.
ask your
Thank you.
questions.
Thank you,
Excellent.
ma'am.
Ma'am. We will do
Welcome,
question and
welcome
QA.
everyone. Yes, please today try to solve questions on the CNS that we have been doing always. You have question bank in front of you, or there is a group. You can post your questions there. Like yesterday, everyone in the group was thinking about what is the lesion, where is it localized. So today I thought that we should go ahead with this topic. Okay. So I guess we have Dr. Ramya with us.
Yeah, dear.
Yes, ma'am. Good afternoon.
Good
I'm handing
afternoon.
it over to you.
Thank you, dear.
Yes, ma'am. Give me a minute. Pallavi, ma'am, how do I make them the host, or you can make them the host? Make host.
Hello. Yes, ma'am. Make me host now, please.
Yes. I have made Dr. Ramya, ma'am, the host.
First, make me the host. Yeah.
Okay.
Okay. You have make host to Dr. Ramya. Okay, ma'am. Can you share the screen, Dr. Ramya, ma'am? Please check.
Yeah, I started sharing.
Okay, ma'am. No worries. Yeah. Now it's done. You can go on, ma'am.
Okay, fine. Hi, good afternoon to everyone.
Good
Am I
afternoon.
audible?
Good afternoon.
Yeah. So I think this is my first mock class. So I'm
Good
Dr.
afternoon,
Ramya.
ma'am.
Good afternoon, dear. Zuleika, Rabia. I know only few guys, sorry.
Thank you,
But
ma'am.
I want you people to be very active and interactive. Okay, I will not be reading the question. I'll just tell the names, and you people should actively participate with me. Okay.
Okay, ma'am. We'll try.
Okay. Come, let's start then. So, this is my introduction. So, I am working as a specialist in International Modern Hospital, Dubai. I'm a laparoscopic surgeon, and I have been as a faculty in All India all AICOG, and also like I have multiple publications in articles in giving public awareness. So, coming to the, I'm sorry, why this went like this? 1 minute. So today we'll be going through the mock test. Okay, I think you all know these are all the faculties of our MCQS, and Munjal Sat, I thank him for giving me an opportunity to take a mock today. And we'll just go through the first question. Okay, who is gonna read first question? Yeah, Dr. Sandhya, you're there? Okay, Dr. Abia,
Yes, ma'am. Ma'am.
you can read. Sandhya can read. Yeah, Sandhya, read.
Yes, ma'am. I'm going. 50. Sandhya,
56
you can.
year old.
Sandhya read. Sandhya got into Sandhya read.
Good afternoon, ma'am. Yeah,
Good
this is a
afternoon.
56-year-old woman. She's menopausal for 6 years and she's presented with postmenopausal bleeding for 10 days. She has a BMI of 34 and type 2 diabetes and hypertension. She's not on HRT. On examination, cervix appears normal. Transvaginal ultrasound shows endometrial thickness of 9 millimeter. So what is the next step, best step in management? One is repeat ultrasound after 6 weeks, endometrial biopsy, start progesterone therapy, and the last one is diagnostic hysteroscopy only.
Endometrial biopsy, ma'am.
Endometrial biopsy.
Endometrial biopsy.
Sandhya? What is in your mind?
You and she's
This
not on
question, what do you
HRT.
think? Yeah. See, start reading a question from initial, like 56
Yeah, she's
or
56-year-old woman
56.
and
That means she's a
menopause.
postmenopausal lady. And she got menopause for 6 years, now presented with postmenopausal bleeding for 10 days. Okay. So this is a case of postmenopausal bleeding. Then you should think of your DDs. What are the DDs over here?
Ma'am, the answer is B, endometrial biopsy, because since she's a menopausal woman and she's bleeding, and she's hypertensive, diabetic, because these are the comorbidities she has. And she's not on HRT.
So a postmenopausal bleeding, what are the differential diagnoses? It can be endometrial cancer, cervical cancer, or endometrial polyp, or simple endometrial atrophic bleeding also, right? Endometrial atrophy, 60% of the cases, simple endometrial atrophy, which even causes bleeding.
But the thickness is
But
more, ma'am. Thickness is around
yeah,
9 millimeters. Yeah.
I'm just telling you the DDs, okay? So
G.
here, along with that, there are certain risk factors. BMI 34, diabetes, hypertension. What these
Yeah.
three risk factor indicates?
She's
She's a
in a
See
case of
high level.
endometrium.
Yeah.
See
metabolic
endometrium.
syndrome. She's a case of metabolic syndrome. So
Mm.
when there is metabolic syndrome, there is increased estrogen synthesis, and they have also given that cervix appears normal. And scan
Yes,
is showing endometrial thickness of 9 millimeter.
yes, ma'am.
Got it? So in a postmenopausal lady who has been not bleeding for 5 or 6 years, what should be the normal endometrial thickness? Zuleka, what should be the normal endometrial thickness?
5 mm.
Yeah, 4 to 5 millimeters is a normal
Less
endometrial
than 5
thickness.
mm.
Madam,
Yeah.
more than 5
Less
mm.
than 5 is normal.
4 to
Less
5.
than, actually 4 they say, but in certain literature they even say 5. So we can
5.
take as like a range, 4 to 5. So less
Yes,
than
ma'am.
5 is normal, more than 5 is abnormal. So see, they asked next best step in the management. Okay. So here, repeat ultrasound after 6 weeks, no, we have to evaluate the patient, right?
Yeah.
Endometrial biopsy, yeah, it's good. Start progesterone therapy, no. Without ruling out of cancer, you cannot start any progesterone therapy. Diagnostic hysteroscopy only. It's not like diagnostic hysteroscopy with endometrial biopsy. If that is given, that would be the first option.
Yes,
Are
ma'am.
you people getting me?
Yes, ma'am.
Yes, ma'am.
So here, as there is no other best option available, it is endometrial biopsy. And it's the next best. See, always read these points. Like, see, when you read the question, yeah, answer here, I know, you people know. You should always read what is given here. Like, is it the next best management? Is the initial management? Or what is a definitive management? So the answer depends upon to that. So read the question properly, and you should always keep in mind what they ask. Sometimes they will also ask like what cannot be done. So here the answer is, as Sandhya told, it's correct. So it's an endometrial biopsy. So here you should think that whenever you get a postmenopausal bleeding, you should think always the differential diagnosis. And here, because she is a case of metabolic syndrome and they have written cervix is normal and her scan is showing thickened endometrium, the next best step would be endometrial biopsy or hysteroscopy with biopsy. Has the question like option D is not correct because it is mentioned only diagnostic hysteroscopy. So it's not like that. We go with diagnostic and also with the biopsy. Am I clear?
Yes, ma'am.
So any postmenopausal bleeding, if the endometrial thickness is more than 4 millimeter, biopsy should be done first. Okay? Very good, Sandhya. You did very good. Next, Dr. Rabia.
28 years old woman present with 6-week amenorrhea, lower abdominal pain, spotting, urine pregnancy test is positive. She is hemodynamically stable. Transvaginal ultrasound, no intrauterine sac is there. Adrenal mass varying 3 centimeter, minimal free fluid in the free fluid, beta HCG is 1200.
Yes.
So it could be the case of ectopic pregnancy
Read question
and
completely. Most appropriate management. So what is your most appropriate
most
management?
most appropriate management is methotrexate therapy here.
Yes, very good. Any other people want to tell anything else? Any different opinions? Zuleika, Sandhya? All agree
Yes,
with
ma'am.
Rabia?
Yes, ma'am. Medical management. It is the medical management for the molar pregnancy, ectopic pregnancy.
So see, when you actually, I have explained this in your previous class. So ectopic pregnancy,
Yes.
you have medical criteria, you have physical criteria, hemodynamically stable, scan is showing adnexal mass which is less than 3.5 centimeter, beta HCG is less than 5,000, and there is only mild abdominal pain and spotting. Okay, and the most appropriate management would be here methotrexate therapy. Am I clear?
Yes, ma'am.
Okay.
Clear.
Why it's not emergency laparotomy? Emergency laparotomy, if the same question has been given, severe abdominal pain, hemodynamically unstable, pulse 140, BP 90/60, TVS or like abdominal scan shows severe hemoperitoneum. Irrespective of beta HCG, you have to go with emergency laparotomy. Okay. If the same question, it comes like mild abdominal pain, UPT is mildly positive, hemodynamically stable, on transvaginal sonogram, there is 1 centimeter adnexal mass, beta HCG is 1000. Then what would be the most appropriate management? Expectant management or conservative management. Am I clear?
Yes, ma'am.
So, in ectopic, anything can be given. You have three categories. Like you have to divide your thing into conservative management, medical management, surgical management. Keep these things in your mind. More than 3.5 centimeter, cardiac activity plus, and hemodynamically unstable. Okay, hemodynamically unstable. So all these things, severe pain, hemoperitoneum, all these things for surgical management. Stable, mild pain, less than 3.5 centimeter, beta HCG less than 5,000, and all these things fits into medical management with methotrexate. Conservative management or expectant management, when the beta HCG is less than 1,000, patient hemodynamically stable, who can come for review. That is very important. You have another question also, social history. So you should tell them, whoever on conservative or medical, you should tell them that you have to review every week with beta HCG until this becomes negative. So if you are ready for that, then only go with conservative or medical management. If the husband is not in situ, patient stay 80 kilometers away, then you cannot give medical management. You have to explain them. Am I clear?
Yes, ma'am.
Yes, ma'am.
So
Clear.
here methotrexate is so B is the correct option. So patient is stable, mass is less than 4 centimeters, beta HCG is less than 5,000. So we choose methotrexate. Okay. Next question, who is going to read?
Yes, ma'am.
Yeah, Zuleka, read.
Yes. 32 years old, primary gravida at 35 plus 4-week gestation, present with a headache and blood VN. BP is 170, 115 mmHg, and two readings 4 hours apart. Urine protein is 3 plus. Platelet count at 90,000. Liver enzymes are elevated. What is the best next step? Oral labetalol or observe magnesium sulfate and betamethasone and wait till 37, induce labor without magnesium sulfate. So here, ma'am, we start the magnesium sulfate and immediate delivery. Because the patient in the preeclampsia and in going to the HELP syndrome.
Okay, Akbar Anur, you told, did you give answer for this? Akbar Arun, is he active? No. Okay. So your answer is B right here?
Yes, ma'am.
Yeah. So see, here what is the diagnosis?
Ma'am, preeclampsia and HELP syndrome.
HELP
Is it
syndrome.
simple preeclampsia or severe preeclampsia?
Severe preeclampsia.
Abhi, tell me, Abhi, what happened? What is your diagnosis here?
Help, ma'am.
HELP. So in HELP, what is the treatment?
If the patient is less than 34 weeks pregnant, then we give steroids and wait for 24 hours. Meanwhile, we manage the blood pressure. But if she is more than that, we try to deliver the baby.
Help deliver the baby, ma'am. Control
Okay.
fit and deliver the baby.
Why is MGSFO given?
Prevent fits, ma'am.
So here even D option, induced labor without MGSFR, is also an option. So now this comes into severe preeclampsia with HELP 170, 115. What is the next complication that's going to happen?
She's a
Ma'am,
ma'am.
patient
She's
will develop the fits.
Yes. So to prevent fits, one thing you have to give MGSFR as prophylaxis, control BP, but to control BP is oral labetalol, correct? No.
Yes, ma'am.
My first option
No.
is not
Yes,
correct.
yes.
Betamethasone and wait till 37. HELP syndrome, just be blind. Just deliver. Delivery is the treatment. So here, it's a HELP syndrome. As Abhi told, it's more than 34 weeks. HELP syndrome, immediate delivery. Even if it is less than 34 weeks, a patient whose platelet count is less than 90,000 and like elevated liver enzymes, that means the patient is going into HELP. The next step would be DIC. If you won't intervene, you are thinking the baby is small, baby will be preterm delivery and all those things, but mother is under compromised. So always, if mother health, baby health, if both are under risk, who should be given first importance?
Mother.
Yeah. So
Mother.
irrespective of the gestational age, whatever it is, if the BP is 170 by 115 on 2 occasions with urine 3 plus, platelet count 90,000, liver enzymes elevated, the next best step would be delivery. Along with that, we give MGSO4 to prevent eclampsia. Here, you don't have time, so it's a primary gravida. Yeah, if at all the cervix is so good, you can induce, but otherwise we'll go with LSCS, emergency LSCS. Am I clear?
Yes,
Ma'am,
ma'am.
so we will give magnesium and delivery, or we will control the blood pressure first. Sorry, I was offline for a while.
All simultaneous. All simultaneous. You call for help, put IV cannula, give IV labetalol, give magnesium sulfate, prepare for delivery, call the operation theater because platelets are less, arrange blood. So it's not like a single event. See, of the 4 options, which is the best one? If they have given IV labetalol, control BP and magnesium sulfate and delivery, that would be the best and appropriate one. So that's why I'm not concentrating on the answer. Just read all the options. Choose the best next step. Now I gave only MGSO4 and immediate delivery. But tomorrow in the exam, they may give the other option. You should choose the
Yes, ma'am.
best next step. Got me? Here, why
Yes,
betamethasone
ma'am.
is not given? Betamethasone is not given. Already she is 35 plus 4. As per the guideline, 34 plus 6, like till 35 weeks, you can give betamethasone. You cannot, giving 1 dose of betamethasone is okay, but you cannot wait for the betamethasone dose to complete to deliver. That is a funda. That's why I'm not insisting on giving betamethasone here. Here, the mother's health is very much compromised. You directly go, give magnesium sulfate, immediate delivery. The diagnosis is severe preeclampsia. Even if it is severe preeclampsia with so compromised mother, you will go and deliver the baby. Am I clear?
Yes, ma'am.
Abhi?
Perfect.
Abhi,
Yes, ma'am.
next question
Very
for
clear.
you.
Thank you so much. A 45-year-old woman presents with heavy irregular menstrual bleeding for 6 months. She has completed family. Hemoglobin is 9. Ultrasound shows bulky uterus with endometrial thickness of 14 millimeters. Is the most appropriate next investigation? Pap smear, endometrial biopsy, hysterosalpingiography, MRI pelvis.
Tell me.
Pap smear.
Any other opinions?
Maybe because of her age, she's 45 and near menopause.
Ma'am, I would prefer endometrial biopsy.
Explanation, please.
Yes.
Why do you prefer that? Why not pap smear? Here they didn't mention anything about the cervix.
Yeah,
even
endometrial
cervical
thickness
causes.
is too much. Endometrial thickness is too much. It's 14 millimeters.
Yeah, that should come out, Rabia.
They not
So
mention
why
about
you
the
are telling
cervix.
here? Answer is endometrial biopsy for sure, because they see, first thing is irregular bleeding. When will the irregular bleeding come? When there is
Then
anovulation.
endometrial. Yes.
Anovulation. Along with the anovulation, you are here. They're also telling that the patient is having hemoglobin 9. That means she's bleeding since 6 months, and her endometrial thickness is also 14 millimeter. So usually, as I told, 4 to 5 in postmenopausal lady. In the same way, in the perimenopausal age group, 12 millimeter is a normal. 12 to maybe 10 to 12 will be the normal. And this also depends on which day of the period this scan was done. But if it is more than 12 millimeter, always go with an endometrial biopsy to rule out malignancy. I do agree, Abhi, as like cervix was not mentioned, and there is a possibility of thinking pap smear, but here the clinching word is irregular. That means there is anovulation. Along with the anovulation, there is thickened endometrium. This both clinches that the cause for AUB would be endometrium, not the cervix. Okay? Any abnormal uterine bleeding, what is the classification? How do you classify them? Zuleka, how do you classify them?
Palm coin, ma'am.
Yeah. So in this, polyp ruled out, adenomyosis ruled out, leiomyoma, fibroids ruled out, malignancy not ruled out, we don't know. And coagulation abnormality she doesn't have, because since 6 months only, it is not from menarche. Got it? O is anovulation. So irregular cycle means anovulation. I is iatrogenic. She is not taking any medication. E is endometrial cause. Unless until there is no other cause, then only we'll go with endometrium. N is not specified. So here our two DDs are, one is malignancy, one is ovulatory dysfunction, right? Of these two, which is more common in perimenopausal? So ovulatory dysfunction that may lead to malignancy later on. And here the clinching word is endometrial thickness is high. So we have to go with endometrial biopsy. Even if you go with the other options, only pap smear is appropriate. Only two things only we do, right? Pap smear and endometrius. But most appropriate means of the two, you have to choose one. Abhi, am I clear?
How
Yes,
to
ma'am.
exclude
Yes, ma'am.
adenomyosis?
Okay. Is someone having doubt? Mifra, tell me.
Ma'am, adenomyosis, how did we exclude?
If, see, in the scan report, they told that it's bulky uterus. They didn't mention any adenomyotic patch. Bulky, that means it can be adenomyosis, but they have not mentioned. And usually in adenomyosis, the scan, what happens is, I'll show you. If this is the endometrium, and if the adenomyosis is on the anterior, so there will be disparity. This will be more thickened and this will be thin. So the disparity will be there. You have certain appearance like pine leaf appearance in USG or the endomyometrial junction. This is endometrium, right? And this is myometrium. So this endomyometrial junction is not well defined. What is adenomyosis? Mifra, tell me what is adenomyosis?
Thickening of the endometrial wall, ma'am.
Huh? No. This endometrium, which should be in the endometrium, if it shifts into myometrium and sit in the myometrium, along with the menstrual period, in the myometrium also there will be bleeding because this blood will not come out. This has outlet. So when the endometrial glands are present in the myometrium, then this will become adenomyosis. Am I clear? So that's why these patients will have severe dysmenorrhea. And that's why this endometrium and this will thicken this and the endomyometrial junction is not clear. In a normal uterus, the endometrium will be only inside and it should not, this myometrium will have no other thing. But here, when this endometrial glands shift into myometrium, this is known as adenomyosis within the uterus. If it is going outside the uterus, sitting in the ovary, sitting in the tube, sitting in the POD, then what it is called? Mifra.
Endometriosis.
Yeah, that's it. So that is the difference between the adenomyosis and endometriosis. So in the scan, if they have given that, yeah, there is, along with the bulky uterus, if they have mentioned that, yeah, there is irregular thickening of the anterior wall of the uterus or pine leaf appearance in the scan or endomyometrial junction is not well lineated, that clinges to adenomyosis. What is the diagnostic like investigation of choice for adenomyosis? It's an ultrasound. So if the ultrasound has not mentioned it's not adenomyosis, then don't worry. That is not adenomyosis. Am I clear?
Yes, ma'am.
Okay. So next question Mifra will be doing. Okay. So this is endometrial biopsy, more than 45 years, anovulation, rule out malignancy, khalas. Next. Mifra.
A woman delivers a 4.2 kilo baby vaginally. After delivery of the head, shoulder fails to deliver. Turtle sign is present. What is the first maneuver to be done? Zamboni maneuver, McPert's maneuver, clavicular fracture, fundal pressure. Clavicular fracture.
Ma'am, make robot maneuver.
Hey Zuleka, let Mifra answer
Yes.
now. I know you are a gynecologist. You know everything.
Okay. Sorry.
Mifra, tell Mifra.
Ma'am, I don't know the first two maneuvers anyways.
Okay, it's okay, no problem. You can do mistakes here only so that you remember it lifelong. When you do mistake, when you admit mistake, you will not forget it forever. So no worries. So let me tell you now, Zuleka, you can tell what is your answer.
Ma'am, my answer is the make robot maneuver.
Okay, so would you explain what is McRoberts maneuver?
Yeah, ma'am, we put the patient's legs are hyper extended and
very good. Legs are hyperextended. Zuleka, hyperextended means both legs are onto you, not onto the abdomen, onto you. She's kicking you.
Up to the abdomen. Up to the abdomen.
So let me tell you. Yeah, let me tell you.
Yes.
First of all, what is shoulder dystocia? So in the pelvis, when the head comes out, but the shoulders are stuck in the pelvis, that is known as shoulder dystocia. Mifra? So how will you diagnose shoulder dystocia? That like how turtle keeps her head, like comes out, then it goes inside like that. Because the shoulder is stuck here, the head will not come out completely. Got it? So that is what turtle sign. So this clinges the diagnosis as?
Shoulder dystocia.
Yeah. Now, what all things you do to get rid of shoulder dystocia when a patient is in labor? First thing, call for help because you cannot do it by yourself. You have to call many people for help. Got it? Patient will be putting lot of fundal pressure. You have to tell, stop fundal pressure. Don't give fundal pressure, because the more the mother tries to push, the more and the more the shoulder will get impinge onto the pelvis, and the shoulder will get more stuck. So stop fundal pressure. Then what can be done to increase the pelvic diameter? That is McRoberts maneuver. That means nothing but you ask the patient to, if the patient is lying like this on the table for delivery, okay, usually the legs will be like this, right? You hyperflex. That means bring both the legs close to the abdomen. Hyperflex the legs and also thigh. What will happen with this? The anterior pubic symphysis and posterior sacrum will move apart, and this pelvic diameter is there na, whatever this pelvic diameter is there na, so
Increase.
this pelvic diameter will increase with McRoberts maneuver. Got it? Still 90% of the patients after McRoberts maneuver, the shoulder will deliver. Still the patient has not delivered. Then the next thing that you give is suprapubic pressure, because here is the shoulder stuck, right? So from above you give pressure so that shoulder just move to the space. So usually in the outlet, anteroposterior will be more wide. So if you give suprapubic pressure and make this transverse shoulder into anteroposterior, the delivery will be more appropriate. The second maneuver that you do is suprapubic pressure, right? Still the patient didn't deliver. Then what you should do? Zuleika, what you will do? Gynecologist on
Then,
call.
yes, yes.
Then put your
Then,
hand inside the
um,
vagina.
yes.
Deliver posterior arm. One arm you deliver. Then the shoulder overall diameter will reduce, right? So deliver the posterior arm. So now, Mifra, what is the first maneuver you do? Mifra, first maneuver.
McRoberts maneuver.
Second maneuver. Hello. Suprapubic pressure.
Suprapubic pressure.
Third one, you can extend the episiotomy, wide the space, and bring the patient to the edge of the table. Then put your hand and try to deliver posterior arm. There are other fancy delivery methods, like there are other like Rubens 1, Rubens 2, all those things are there. Corkscrew, wood corkscrew, all these things. I don't think that is so important for you. And after doing these three, even the head is not coming. What is Janavalli maneuver? After you tried everything, but still
I
the
think
head
the
is not, shoulder
I
is
think the
not coming.
patient
Then kilometer.
the patient stays on the patient assumes the all four positions. All the four limbs will be on the examining
Yeah,
couch. All four limbs.
yeah, that is just before Zanavali, we'll give all four positions that will improve more space, and you can try that as a next before Zanavali. After that also, if all four done, even then also not coming, then Zanavali means
Kilometer.
how the head came. In the same way, you have to reposition the head into the pelvis and do cesarean delivery. You cannot do clavicular fracture or like destroy the baby and like pull the baby. All those things are nowadays avoided.
Almost
So,
less.
so Zanavali is the last maneuver. You keep how the head came out in the same way you keep inside. Emergency cord purple. Take for emergency LSCS. Deliver the baby from above. Kalas?
Yes, ma'am, understood.
So, shoulder dystocia, keep in mind, McRoberts maneuver, avoid fundal pressure, give suprapubic pressure. Then also if baby 90% will come, but if it's not coming, deliver the posterior arm. Then still not coming, all four maneuver. You have to keep patient in all four position. After that also it's not coming. Then Zanavalli maneuver, LSCS. Okay?
Yes.
Actually, I thought this is a mock. That's why I didn't bring many big images. I thought I'll explain you. So, am I clear without images?
Yes, ma'am.
Yes, ma'am.
You can just go through this in YouTube, or like you can just search the photos and see. Here the question is first maneuver to be done.
They
First maneuver is always macrobuds. Okay. If the same question asks, what is the last maneuver to be done if the baby is not delivered? The answer will be, Mifra?
7 maneuver.
Yeah. Zavanelli maneuver is the last maneuver. And there is another question about that that will go with the next thing. So shoulder dystocia is an emergency management. And if the same questions tell what is the first thing you should do, and the options are same: Macroberts maneuver, call for help, fundal pressure, Zanavelli maneuver, Zavanelli maneuver, what will be your answer?
Call for help.
Yes, very good. That's why I'm telling you the concept. So read the question, dear, please. What is the first thing that you, or initial step in the management of shoulder dystocia? Call for help. What is the first maneuver to be done? Patient should be in the edge of the table. Then you go with Macroberts maneuver. Am I clear? Please don't go with the question and answer. Learn the concept, dear. The same questions won't repeat, but if you have concept, you can answer any sort of questions. Am I clear?
Yes, ma'am.
Mifra?
Yes, ma'am.
Done. Done.
Clear.
Okay. Next question, Ganiat. I don't know whether I spelled it correctly.
Yes, ma'am, you did. A
Thank you.
24-year-old woman presents with sudden onset, severe lower abdominal pain and vomiting. Ultrasound shows a 66 centimeters ovarian cyst. Recent Doppler flow. The best management.
What is the
Analgesics and
diagnosis,
observation.
dear?
The diagnosis. Is a ruptured ovarian cyst.
Rupture? Okay. What is your best management?
The best management is to do an emergency laparoscopy.
Very good. Your answer is correct, but your diagnosis is not correct. Who is going to tell me the diagnosis? Sunil.
The torsion of ovary.
Yeah, what is your name, HP? Sorry,
Juhaira, Dr. Juhaira.
Okay, Juhaira, tell me what clinched your diagnosis of torsion?
It's a sudden onset of severe low abdominal pain.
Huh?
And there's a ovarian cyst is there, 6 centimeter cyst is there.
See, these all things
And,
can be seen even in rupture. Rupture, sudden ovarian cyst rupture also, there will be severe onset of pain, sometimes vomiting. But here, the word that is absent Doppler is clinging to torsion. Absent Doppler means what it means. There is no flow, no blood flow to the ovarian cyst. When there is no blood flow, that is torsion. So, any acute abdomen with ovarian cyst, what are your DDs? Tell me, Ganiyat.
Yes, ma'am.
One is rupture. As you told, rupture of the ovarian cyst is one of the DD. Number
torsion
two,
ovarian.
Diagnosis, yes, ma'am.
yeah, that is second one is torsion. What would be the third one? Third DD.
Third differential.
Maybe patient with
It could be a ruptured ectopic pregnancy.
Ectopic pregnancy? Yeah. But I'm asking only in ovarian cyst, acute abdomen.
Ma'am, appendicitis.
Ovarian cyst with acute abdomen, I'm telling dear. One more thing is there. Hemorrhage into the ovarian cyst. She had done some workout. And there is a possibility that any of the vessel rupture, and whatever 6 centimeter ovarian cyst is there, it will become, maybe this was simple one which is 3 centimeter. Once the vessel ruptured and there is hemorrhage into the cyst and then it became 6 centimeter. So that could also be a differential diagnosis. I'm not telling what are the differential diagnosis. If there is ovarian cyst with acute abdomen, then your DDs will be torsion, rupture ovarian cyst. Third is hemorrhage into the ovarian cyst. But here the clinching word is absent Doppler. Your diagnosis is torsion ovarian cyst. So your best management would be emergency laparoscopy. See, what is torsion, you know, right? Along with the tube and ovaries, it twists around itself so that the blood supply to the ovary is compromised. So you have to retwist to the original position, detorsion to the original position, look at the vascularity of the ovary, whether it has been regained. Then you can remove the cyst, keep the ovary there. If the patient has been in torsion for a long time, these all become necrotic. How will you know it is a necrotic one?
Impaired blood supply.
Yeah, so it will be black. On laparoscopy, when you see, it will be black. Then that is, if the ovary looks black, then immediately remove everything. That means it's necrotized. It has undergone torsion and it would be a surgical emergency. You should remove the ovary also. But recent guidelines have been telling a bit different. But for you guys, if there is blackness, necrotic tissue of the ovary, that means it's torsion. You have to go with the removal of the ovary. Okay?
Yes.
Am I clear?
Yes, ma'am.
Dr. Zuwaria, something like that, I think HP, that means. Read question number 7. Oh, sorry. I'm sorry.
A
Yeah, read.
30-year-old primary gravida at 20 weeks of gestation with no risk factors attended ANC. What is the recommended screening test? HbA1c, fasting blood sugar, 75 gram oral glucose tolerance test, random blood sugar.
What is your option?
So her ANC was uneventful previous visit. So we can go for we had to diagnose whether she's having the gestational diabetes mellitus. So I will go for the 75 gram oral glucose tolerance test first.
Very good. Wonderful. So why at 24 weeks, dear? If this same question comes telling that the patient is at 12 weeks of gestation with no risk factor, now will you screen the patient with 75 gram OGTT?
No, ma'am.
The question is
Random.
open. Yeah, you can ask. You can tell. Anyone can tell.
Random blood sugar, ma'am, then.
Zuleika?
Yes, ma'am.
Rabia?
HbA1c, ma'am. Because she is already diabetic before 12 weeks of pregnancy. It means not the gestational diabetes. It is the already diabetic patient.
Yeah.
HbA1c.
Okay. Any other opinion?
It's not mentioned. No, she is a diabetic patient. So I will go with the random blood sugar or PPBS.
Usually we diagnose the gestational diabetes mellitus after 20 weeks.
All they are right, but answer is 75 gram oral glucose tolerance.
Very good.
Ma'am,
So,
I want to ask if someone is already diabetes, so and conceive, and then during pregnancy, what will be the changes? You explain today.
I'll surely tell you. So there are two entities, that is over diabetic and that is GDM, gestational diabetes. See, gestational diabetes, the word itself tells that it is because of the gestation the patient is diabetic. So gestation, what happens that the patient become diabetic? At 20 to 24 weeks, there are certain hormones like cortisol, HPL. This will increase and this will cause insulin resistance in the body. Because they get insulin resistance, they become diabetic. So this occurs only if the mother is pregnant, that is at 24 weeks, that is gestational diabetic. If the patient comes to you, see here, the clinching words are primigravida, no risk factors, no risk factor. If a patient comes with risk factor, like see, a multigravida who had previous deliveries, 5 kg baby, who had GDM in previous pregnancy, whose parents are diabetic. So these are all risk factors. Am I clear? If she comes with risk factors at 12 weeks, if without risk factors at 12 weeks, nothing to be done. Maybe you can go with a random blood sugar or HbA1c, that's up to you, because random blood sugar, HbA1c, or fasting blood sugar, these three can depict whether she is over diabetic. So of these three, it's your choice. Whatever can be done. But at 12 weeks, when to do? One with risk factors. Okay? At that time, if the HbA1c is more than 6.5, if the random blood sugar is more than 200, if the fasting blood sugar is more than 120, these three, any one is positive, then you call them it as over diabetic, because the diabetes is not because of her pregnancy. She is already diabetic. Am I clear?
Ma'am,
There is a
those
12-week
patients,
mark on that.
I'm sorry.
ma'am, for those patients who are over diabetes and we detect 12 weeks, do we have to do at 24 to 28 weeks again
Why you
OGTT?
do? Why you
No
do?
need.
Already you diagnose them as over diabetic. See,
She
why
is
you
already diagnosed case.
Ma'am, my
already diagnosed over diabetic, then she will come into category where her sugars should be controlled. She will be referred to endocrinologist. The sugars will be either controlled with OHS or insulin. Then there is no point in doing GTT. See, glucose tolerance test is done only to diagnose gestational diabetic who are at high risk, but till now they are not diabetic. So whether they will be diabetic or not, to know that, we give a glucose challenge. After glucose challenge, if the sugars are high, then we tell them as diabetic, gestational diabetes, and we need immediately, we will not start treatment. We'll go with diet, we'll do exercise, and we will tell that you are high risk. You should be under regular follow up. That's it. In over diabetic, if you diagnose as over diabetic, you will not wait, because already sugars are very abnormal. You will directly go with treatment, OHA or insulin, according to the sugar level, to what extent the sugars are abnormal. According to that, you treat them. So you understood, these are screening tests. These ones become positive, high, directly you label them as like over diabetic. In the GDM, I think I have already covered this in your regular class. So if it is a GDM, usually you have two bodies, like two big bodies have given their own recommendations. That is, let me tell you, that is like you have ACOG and you have UK guidelines, RCOG. Okay. What this ACOG tells is, if the patient has risk factors, you go with 50 gram GCT. After 1 hour, you check sugars. If it is more than 140, then this is screening test positive. Now you go with diagnostic testing 100 gram GTT, 100 grams GTT, where you take 4 samples. You take fasting sample, 1 hour, 2 hour, 3 hour. Of these 4 samples, if two are positive, then she is labeled as gestational diabetes as per ACOG body. RCOG or even UAE follows 75 gram GTT if the risk factors are there, because see, Arab countries are more Arab, Indians, Pakistanis. So these are the area where they are more prone for diabetes. So they directly risk factors are there. We go directly with 75 gram GTT. This is also diagnostic test where you do fasting 1 hour and 2 hour, only 3 samples. Of these three samples, if one sample is positive, these people are labeled as gestational diabetes. So either if the question, they will mention that as per ACOG, or they'll mention that as per RCOG. If they have not mentioned anything, you can take UK like RCOG and you can think that, yeah, 75 gram GTT is ideal. Am I clear?
Yes, ma'am.
So I
Yes,
know
ma'am.
it's like all of a sudden I'm giving you a lot of like knowledge. So this is the screening strategy. This is for GDM or over diabetic, Mifra. This is for GDM or over diabetic.
GDM, ma'am.
GDM. It is for GDM, not for over diabetic. Once over diabetic is diagnosed, then they'll go directly to the other pathway to endocrinology, sugar control, all those things. If the patient has not been diagnosed with diabetic, then only you have to rule out diabetes at 24 weeks. Then only this all drama will come. If this has been already diagnosed as GDM, then already diagnosed as over diabetic, then why you want to do all these tests?
Well, there
Am
is
I
one
clear?
thing. There is one
Yeah,
thing
ask.
I'm a little confused about.
Hmm.
The thing is, since it's related to me, I had gestational diabetes, but I was diagnosed at 23 weeks probably, and it went away after my son was born. Wasn't it gestational diabetes, even though I was feeling the sweet taste in my mouth for a couple of weeks?
Yeah, that is what, more than 20 weeks. After that, you were diagnosed as diabetes. That means it is GDM only. If it is less than 20 weeks or 12 weeks, then only over diabetic. Yours is surely this one. And one more thing, yeah. Post delivery also you can differentiate. Post delivery your sugars have come normal and you doesn't require to take insulin or OHS. That means it reverted back to normal. This signifies that you are more prone for type 2 diabetes in future. Now you are not diabetic. Understood? But in over diabetic, post delivery also you have to continue insulin because it's over. But maybe in pregnancy, whatever dose is given, that dose we can reduce to some extent, because as I was telling you, in pregnancy already, because of this cortisol, HPL, the sugars, insulin resistance will be there, and normal insulin requirement, it will increase the insulin requirement during pregnancy. Am I clear, Abhi?
Yes, ma'am. Thank you so much.
Ma'am, I have another question.
You can ask, because this is a vast topic. You can ask.
Ma'am, in case of when it comes to treatment during pregnancy, diabetes, either it's overt or GDM, we start with the exercise and diet, no, ma'am, first. If it is not
No, ma'am.
controlled,
See,
we go with
if
the
it when you
insulin or
diagnose
oral
no
hypoglycemic.
when you diagnose over diabetic, when the sugars are very high, like random blood sugar more than 200, HbA1c more than 6.5, and fasting is more than 125, that means they are very abnormal sugars. And if that category you give 2 weeks time and the HbA1c after 2 weeks comes to be 10, and what is the problem with over diabetic? The baby also will have high sugars. The baby will be affected with congenital abnormalities. In that situation, GDM, 24 weeks. Kalas, baby's organogenesis is all completed, everything is finished. So, if and this GDM, the extent of sugar abnormality will not be so extensive. GDM, you give glucose water and you are giving glucose. If you drink glucose, your sugars also will increase. But what happened if you have given a glucose shot, immediately your pancreas will secrete more and more insulin and that will be normalized. But among this GDM patient, the insulin will be secreted, but that is not adequate. That's why their sugars are bit high. Doesn't mean that their sugars are abnormal. That's why you give 2 week time with diet and exercise. You ask after 2 weeks to come with fasting blood sugar, postprandial blood sugars. This might be normal. Then you need not to do anything. You just tell them the diet. Again send them. Again come after 3 weeks. Once the sugars, fasting or postprandial sugars are abnormal, then only you intervene to what level the abnormality is. You give OHS. If it is very much abnormal, afterwards, if the patient is coming with fasting sugars more than 200 and all, then also you can't just wait and tell, oh, go for diet. No, go for exercise. No, the sugars are important because these sugars are entering into the baby and it will affect the baby's pancreas or baby's metabolism. Am I clear? So
Yes, ma'am.
usually if you diagnose with GDM, the sugars won't be so abnormal. Usually the sugars will be normal. You can give them diet, exercise, wait for 2 weeks if it's getting control because you are diagnosing with glucose challenge. You are giving glucose and then you are diagnosing. Basically, if these 24 weeks, if you check FBS and PPBS, that will be absolutely normal. Why we are not doing FBS, PPBS and why we are giving this GTT? To see how they respond to glucose and whether there is insulin resistance. Am I clear?
Yes, ma'am.
Yes,
Okay.
perfect.
That's why we go with GTT rather than going with simple fasting blood sugar or random blood sugar. But in over diabetic, what you do? You check fasting blood sugar, you check random blood sugar, you check HbA1c, whether it's controlled or not. At 24 weeks, no risk factors. Why you are checking GTT is to just see whether they are high risk for diabetic. I think now the concept is clear, right?
Yes, ma'am. Very clear.
Okay. Everyone got it? So even the
Yes,
question
ma'am.
tomorrow might come to you like, see, over diabetic with fasting blood sugar 200, fasting blood sugar 140. What is the first management option? Please don't give diet and exercise. Give OHA or insulin. Or if the option tells refer to endocrinologist for sugar management, option that. Okay? If same question comes at 28 weeks, GTT showing abnormal sugars, what is the next management option? Diet, exercise, and follow up. After 2 weeks, then after 2 weeks, will you again do GTT? No. You diagnosed, then the next, after 2 weeks, when you call them, you just do fasting sugars and postprandial blood sugars. Am I clear?
Yes, ma'am.
Yes, ma'am.
This concept is bit, you have to learn the concept. Then you can solve any question from GDM or over diabetic. And the other thing is GDM over diabetic. What is the difference? Over diabetic, there will be high HbA1c, baby will be affected. Congenital abnormalities are common in over diabetic. But GDM, will they have congenital abnormalities? No, because 24 weeks already organogenesis has been finished. Very less possibility to have congenital abnormalities. But GDM babies will be big baby and they are more prone for shoulder dystocia or like metabolic abnormalities after delivery, like they go with hypoglycemic attacks or they have this hypocalcemia, polycythemia, all those things. Am I clear?
Yes, ma'am.
Yes, ma'am.
Along with this, you solve some more questions on GDM. You will get to know, okay? So GDM, see, let me tell you, GDM and over diabetic is DHS favorite topic. So please solve few questions on it and get to know what is the answer for what. If you have any doubt in that, you can tag the question in the group. I will answer it. So this IADPSAG is nothing but it's the RCOG. People follow this IADPSAG, which is universal screening. Am I clear? Can we go with the next question?
Yes, ma'am. We can continue.
I'm sorry. I think I have loaded you with a lot of information about diabetic.
But ma'am, it's interesting and very knowledgeable for everyone.
Rabia always gets interest in my class. Rabia will tell this.
Because I'm
You are the
learning.
same, right?
I'm learning.
You are different?
Yeah, ma'am.
We are not
No, ma'am,
bored
I'm
with
the same.
teaching, ma'am.
Okay.
My laptop is disconnected, so I'm using mobile data now.
Okay, no problem. So anyway, if you people are if you people understood the topic, that's enough, dear. You can solve n number of questions with the concept. Now I'll call the some like who is not so active. Rajesh, not
Yes,
there?
ma'am. Yes, ma'am.
Yeah, thank you,
Yes.
dear. You are also active in the class then. Yeah, read the
Hi.
question.
A 36-year-old woman with no
Hmm?
symptoms asks about cervical cancer screening. Best
Hmm?
screening test: A. Pap
Yeah.
smear every year. B.
Hmm?
HPV DNA testing. C.
Hmm?
Colposcopy. D.
Hmm?
Endometrial biopsy.
Hmm.
Okay.
What
Pap
do you
smear
think?
every year. A.
Mm-hmm. Okay. Any other opinion? Rajesh, you
HPV
did
DNA
great job,
testing.
but they ask
Pap smear, ma'am.
these words are very important. Please, please, please note this. If they ask routine screening test, then you are correct, Rajesh. It's pap smear, not every year, every 3 to 5 years. But what did they ask? So it's a
Best screening.
best. They want the best. So what now Kavita will answer me. What is the cause for cervical cancer? Kavita is not active. Abhi, what is the cause for
HPV,
HPV.
Human
HPV
papilloma
16
virus.
and
what
18.
strains? What strains?
16 and 18.
So
16 and
16
18.
and 18.
16
So
and 18.
if
16,
yeah,
18, 6, 11.
yeah. So these two are mostly 90% of the cases are caused by this. So they asked you the best. So best will be always HPV DNA testing. Rajesh, am I clear?
Yes, ma'am. Yes.
Okay. If the question I was asking you, what would be the routine screening test, then your answer would be pap smear.
Okay. Okay.
Okay. So see, as per MOHAP, regular screening of the woman starts at 25 years. Usually pap smear is done every 3 years if the lady is aged between 25 and 29, or every 5 years if the age is 30 to 65 years. And one more thing that you should keep in mind here, the age of the patient is 36, dear. If it is between, if the age is between, minute, hello? Yeah, if the age is between 25 to 29, then pap smear only is preferred, because at that up to 30 years, HPV DNA is found in every vagina or every cervix. It is common. But after 30 years, our immunity will be increased to and it will try to kill all the HPV. So after 30 years only, HPV testing is significant. And if you are doing HPV testing, then you need not to repeat every 3 years. It is only 5 years. Combined means doing both HPV and pap smear. It is the best one. For if you are doing that, then also you do it every 5 years. Immunocompromised, HIV patient, diabetic patient, or renal transplant done on immunosuppressants, those patients you should go with annual screening, because when the immunity is compromised, this HPV will be active and this will cause cervical cancer. Am I clear?
Yes, ma'am.
So this is also one of the favorite topic as per MOHAP guidelines. Please go through this. You read it once again to understand what the things are. And always if they ask routine, then it is PAP. Best HPV DNA. See the age. If the age is less than 30 years, even then best will be PAP smear only. HPV DNA comes into action only after 30 years. Am I clear? Rajesh?
Yes, ma'am. Yes.
Yeah, thank you, dear. Now Kavita is going to read ninth question. Kavita, are you there? Kavita is not there. Krishna, Piyush, Akbar, Arun, anyone?
Yes, ma'am.
Thank you, dear. Who is this? Yeah, read this question.
Yes, ma'am. Hello.
Yeah, dear. Tell me. Read. Piyush,
I am
read.
Piyush Patel. 34-year-old, gravida 3,
Hmm?
Pereira 2, at 32
Hmm?
weeks present with painless vaginal bleeding.
Hmm?
Ultrasound shows placenta completely covering internal os. Bleeding
Hmm?
has stopped.
Hmm?
Base management. Option A,
Yeah.
immediate cesarean section. Option
Hmm?
B, vaginal delivery.
Hmm?
Option C, expectant management with steroids.
Hmm?
Option D, induction of labor at 34 weeks.
Hmm.
32 weeks with painless vaginal bleeding,
What is your
covering
diagnosis?
placenta completely covering internals. My diagnosis is placenta previa.
Very good. Wonderful. Then,
So my answer is immediate cesarean section.
okay. Why you will do immediate cesarean section in this patient where the bleeding has been stopped, Piyush?
Oh,
She came with painless vaginal bleeding. Your diagnosis is perfect. But in the question, it's mentioned that
stopped.
Bleeding
stopped.
stop.
So bleeding will stop. Okay.
Hmm? Now what? What
So
is
we
your
can
option?
go with. So we can go with expected management with steroids. One is
Wonderful.
32 weeks.
Very good. So, Piyush, in the next question, when you solve, you should always, okay, your diagnosis is perfect, but still where the mistake was, you didn't observe that they told that bleeding has been stopped. And
Yes.
now they are asking the best management. So now, if the question is like this, pain with vaginal bleeding and placenta previa, there is continuous, like heavy bleeding, then what is your option?
Then option A, ma'am.
Immediate cesarean section,
Yeah.
right? Huh? So,
Yes, ma'am.
as per the options given, you should go with the solving the question. So now I gave like this, but tomorrow in the exam, they might give you that patient is having heavy flow or in that way. Then steroid and immediate cesarean would be more appropriate. If they have given blood transfusion, steroid coverage, then cesarean, that is also appropriate. Am I clear?
Yes, ma'am.
Thank you, Piyush. Thank you so much. So here, expectant management with strategy, it's not that you people do it wrong. It's okay. It's not the main exam. Don't worry what people will think. You people should be actively involved. Now you do mistake, tomorrow exam you will not do a mistake, but try to at least like be active in the class. Okay. Next, who is going to read the question? Next question. I think this is the last question. I think we can stop with this. So, last question, Krishna, Dr. Krishna, Dr. Kavita, Dr. Akbar.
Ma'am, I'll go for it.
Yeah,
A
38
Kavita.
years.
38-year-old woman with
Huh?
migraine with aura seeks contraception. Best
Huh?
options: A, combined oral contraceptive; B, progestin
Hmm?
only pill; C, copper
Hmm?
IUCD; and D, combined injectables.
Mm-hmm.
Um, I think copper IUCD.
Okay.
One.
Actually, I couldn't get who is reading this question?
I am
Your name, please.
Dr. Ramya.
Okay, tell. IUCD you told, right? Copper IUCD?
Yes, ma'am. I
Why not
think
COC pills?
because they're going to trigger her migraine as well.
Very good. And always, this is the here in this question, this is the thing. Migraine with aura is the thing. So, if migraine with aura is there, please avoid COC pills. What are the other contraindications you remember regarding COCs? Which all patients you should not give?
Aplastic
Second
anemia.
is
I think
Aplastic
she'll
anemia.
answer. Sorry?
Aplastic anemia.
Aplastic anemia. How frequently you see aplastic anemia, dear? What are the frequent if a patient is smoking?
Sickle cell anemia, smoking patient.
What about
Okay.
DVT or
Yeah.
some other conditions?
So smoker
Any
more than 30.
coagulation. Ma'am, any coagulation disorder.
Yeah, DVT, history of DVT. Any malignancies you should rule out?
It leads to hepatoma, so we should do LFT.
Giant cell temporal arteritis, ma'am.
Breast CA.
Okay.
OCP increase
Now,
the
if
risk
there
of
is,
breast CA.
okay, now these options, of these options, it's clear. You can just go with copper IUCD. If there is no copper IUCD, then what you do?
Then progesterone pill. Progesterone pill.
So, POP also good. Combined injectable is all, combined no. Like injectable, only progesterone injectables can be given. So if this copper IUD is not given, then progesterone only pill would be the answer. So see, keep in mind, COCs are contraindicated when there is breast malignancy, when there is any history of DVT, deep venous thrombosis, any history of stroke, diabetes uncontrolled, hypertension uncontrolled, more than 35 years, think twice, rule out all the contraindications and then give my this thing, migraine. These are all the contraindications. Best option always would be copper IUD, but in PID. Will you give copper IUD?
No.
Already patient is having irregular cycles, irregular bleeding on and off. Will you give copper IUD?
No.
So just learn what are the indications, what are the contraindications. If the question has been given, a 38-year-old woman with sickle cell disease came with the contraception advice. What is the best option available? What will you choose? Huh?
Copper IUCD.
IUCD? Why sickle cell anemia, sickle cell disease, and you give IUCD, she bleeds. Her anemia will be HB5. You really want to give copper IUD? Other options, dear? It's a question. Sickle cell disease, you should go with injectable progesterones because it also acts as POP and it acts as a contraception. Along with that, it has an additional advantage of reducing the sickle cell attacks. So that is also a question. Sickle cell disease, always go with injectable progesterones or depot medroxy, DMPA, injection DMPA. Am I clear? Clear?
Yes, ma'am.
Are you guys hungry?
No, ma'am.
Really hungry.
You want to continue the class?
Yes, ma'am.
Okay.
To continue.
Then we'll go with the 11th question. Who is going to read 11th question? Ibn Nazar. Venuri. Tushar. Anyone?
Can I read it?
Yeah, sure.
A 29-year-old primary gravida at 33 plus 5 weeks has a BP.
Sorry, dear.
A 29-year-old primary gravida at 33 plus 5 weeks has a BP 150 by 100, urine protein 2 plus, platelet count 95,000, normal liver function, no symptoms. What is the most appropriate diagnosis? Gestational preeclampsia. Preeclampsia. But platelets are low.
What is the cutoff of platelet count to call whether it's a preeclampsia or it's a HELP?
Mm,
Piyush,
yes,
you want to tell something? Ganiyat, you want to tell
Your
something?
function test is normal, so help is ruled out.
Eclampsia.
Help, Piyush, what are the components in help?
As elevated liver enzymes, low
Huh?
platelets,
What is H? H
and
for?
hypertension.
No, man. It's hemolysis.
hemolysis.
H is for
Ma'am, what is
hemolysis.
AFLP?
AFLP is acute fatty liver of pregnancy. That is different entity where the patient presents with the DAC. I just kept that as a DD. So here it can be gestational thrombocytopenia also, but why not? Because the BP is high,
BP is high.
urine protein is 2
Protein.
plus.
Proteinuria.
So if BP is normal, urine protein is normal, negative, then that can be gestational thrombocytopenia, which is seen in the 3rd trimester. Am I clear?
Yes,
And what
ma'am.
is the cutoff platelet count?
1 lakh.
Anyone can answer.
90,000.
90,000. 90,000.
In help,
No.
you want to ask in help?
80,000, ma'am.
Yeah,
Is
what is
80.
the
80,000
normal
in help.
platelet
80,000.
count?
150 to 400,000.
150 to
Yes,
450,000.
1.5 lakh. 1.5 lakh. I think someone told me. So 1.5 lakh, above 1.5 lakh is normal. Less than 1.5 lakh in pregnancy has to be evaluated. 95,000 means there is low platelet count that can be either because of gestational thrombocytopenia, immune thrombocytopenia, severe preeclampsia leading to HELP. Here, because BP and urine protein is plus, you call it as HELP. If these both are normal, you call it as gestational thrombocytopenia. Because gestational thrombocytopenia platelet count will not go very much down. If the same question with everything normal, platelet count 10,000. Will it be gestational thrombocytopenia? No. In gestational thrombocytopenia, usually up to 75,000 only. It will not go beyond that. So gestational thrombocytopenia is mild variety. So if it is platelet count is only 10,000, that means it's severe thrombocytopenia. That means that is immune
Then it
thrombocytopenia.
is
ITP. So
ITP.
here I have covered you 3 questions. Okay. Actually, I wanted to just go through one more question. 1 minute. Let me check.
Ma'am, so the last one now, what we discussed is HELP or preeclampsia?
Now, last question answer is HELP because protein is 2 plus and the protein is 2 plus, urine protein is 2 plus, platelet count is very less. So that is HELP
Then
syndrome.
95,000.
What is this?
And normal
Then
liver function. There is
95,000.
no signs of hemolysis. as well.
95,000 with LFT normal is counted in the help.
See, girl, of the helper, let me tell you, you have HELLP. Okay. This is complete help. All should be positive. But if anything is positive, then also it is known as HELP only, partial HELP syndrome. Okay. So
Okay,
severe
now
preeclampsia, I'm sorry, severe preeclampsia and this one both are different. Severe preeclampsia help almost equal. Anything can be there. Okay. Now anyone read this question. I wanted to tell you this because you will remove the confusion of diagnosis. Yeah, who is going to read? Yeah, Rabia,
I've
read.
always, yes, at 30 years old primary gravida, 31 weeks gestation, blood pressure is 162 by 110, urine protein negative, normal platelets, normal LFT. Diagnosis should be
gestational.
A preeclampsia, G gestational, C जो है chronic hypertension, D is HELP. So here is the clear diagnosis for gestational hypertension.
Gestational hypertension. So BP is 160 by 110. Still you call gestational hypertension. Why not preeclampsia?
Yes, because there is protein negative, no any signs, preeclampsia signs.
That is what I want to emphasize you. Protein negative Yeah, of course, it's preeclampsia. Protein negative is, of course, gestational hypertension. But as per new guidelines, they are telling if the BP alone is more than 160 by 110, they should be diagnosed as severe preeclampsia or preeclampsia if the urine protein is negative. But here, why the answer is gestational hypertension? Because they have given only one reading. There should be two readings of 160, 110. Two readings of 160, 110 and the urine protein negative, then the diagnosis will be severe preeclampsia. Here only one reading given. So coming to the diagnosis, as per RCOG, severe preeclampsia is defined as severe hypertension where the systolic is more than 160, diastolic is more than 120, and or that means even if proteinuria is not there, it doesn't matter. If only hypertension is there but it is severe, two recordings, then that can be called as severe preeclampsia. If the
Ma'am,
BP,
it means the urine protein urea is now excluded.
yeah, excluded means
New
if it is
guideline,
present,
new
that's
guide
good.
according to new guidelines.
Yeah, if significant proteinuria
Okay.
is there, that's well and good. Even if there is no significant proteinuria, but you have this platelet count less, you have abnormal renal function test, you have abnormal liver function test, you have very high BP recording or any imminent symptoms like severe headache, visual disturbance, severe epigastric pain. So now let me give you a scenario. 24-year primary gravida, BP 150 by 100. Patient came with complaints of headache. On evaluation, the liver function test is abnormal. Urine proteins negative. What is your diagnosis?
Preeclampsia.
Yeah, it's preeclampsia. Even the protein is negative, she is having symptoms of imminent like headache and laboratory findings, either liver function test or renal function test. If anything is affected, that will be considered as preeclampsia. Severe hypertension more than 160 by 110 on two occasions, irrespective of negative proteinuria, that diagnosis is preeclampsia. These are recent guidelines. Previously, in gestational hypertension, edema is one of the one of the diagnostic criteria. Now, edema has been removed. So, even bilateral pedal edema, it doesn't signify anything in the diagnosis of gestational hypertension. To diagnose gestational hypertension, what are the things that should be there?
Blood pressure.
So, BP more than 140 by 90, two occasions. Please keep in mind, two occasions. Okay? And it's gestational hypertension, so it should be more than 20 weeks. If the patient comes at 12 weeks with BP more than 140/90, what is your diagnosis, Piyush?
Chronic hypertension.
Chronic hypertension.
Essential hypertension.
Okay. And after delivery, BP control within 6 weeks. That means?
Gestational hypertension.
Yeah. Gestational hypertension only, but after 6 weeks, still BP is uncontrolled. Patient needs to take antihypertensive. Then
essential hypertension, chronic hypertension.
Chronic hypertension. Okay. More than 20 weeks only, then only preeclampsia diagnosis will come. Please keep in mind, less than 20 weeks, whatever, if BP high and if the proteinuria is plus, it will be chronic hypertension with concurrent preeclampsia. Otherwise, tonic hypertension with proteinuria. Only after 20 weeks only comes gestational hypertension or preeclampsia diagnosis. So these things keep in mind. You can just go through any of the definitions of all these three. Let me see whether I have the definition. I'm not sure whether I have a definition. I think I have taken for Oman class. So the definitions are very simple. Chronic hypertension, you have entity chronic hypertension, you have gestational hypertension, you have preeclampsia, and you have severe preeclampsia or chronic hypertension superimposed with preeclampsia. She is hypertension from 12 weeks. Initially, protein is negative. At 34 weeks, proteinuria with LFT abnormal. That case will be chronic hypertension with superimposed preeclampsia. Am I clear?
Yes.
Yes, ma'am. In this case,
Concept
if
clear?
yeah, concept is clear, ma'am. If isolated elevated liver enzyme with high BP after 20 weeks, no proteinuria, platelets also normal.
2 occasions
Then,
severe hypertension, 160
yeah,
by
2.
110. Then that is
Yeah.
preeclampsia only, dear. Because one thing is BP is high and one of the liver is also involved. Any organ, liver, creatinine, and even elevator enzymes means what are the enzymes that you check?
Liver
SGOT,
enzymes, ma'am.
SGPT.
SGPT.
When you will tell it as anyway elevated? When the levels are?
More than 40.
Yes, very
More
good,
than
Piyush.
40.
More than 40 or twice the normal. Normal is somewhere around 20. So twice the normal is more than 40. Creatinine, when you will tell it as abnormal, more than 1.1. Platelet count, less than 1.5 lakh. Then platelet is also involved. Or even like they have given as 1 lakh, like usually 1 to 1.5 lakh is a normal. In the question, they will not give a value between 1 to 1.5. They usually give less than 1 lakh only. Don't worry for that. Concept clear?
Yes.
These two, GDM, hypertension, please go and read any the basics of the guidelines. Like either you can go with RCOG because that is what you follow. You can just tag me, put a message in the group. This is doubtful. Would you please clear? I'll clear all your questions. Please
Thank
do
you so
solve
much,
because very important topics. I think it's a time to end up here because many of them are very hungry and I took a lot of time. Sir will be like, you took so many. How do you feel? How was the class?
ma'am.
Very
It
good
was
class, ma'am. Nice.
amazing.
Excellent, ma'am.
Happy?
Both of you.
Excellent,
Both
ma'am.
of you.
Very
Both of you.
informative.
Nice
Akankssha and
explanation,
you.
means clear lots of concept.
Thank you, Piyush. I'm very happy. Maybe this was the first class where even like male GPs are also very active. I appreciate that because usually people will be like one side interaction, let the ma'am tell everything, I will listen. But this was really interactive session. I liked it. And I want in future also my classes to be like this only. I will not teach. You teach, I will teach. Knowledge is shareable. Like, I don't know, you will have more knowledge in one topic than me. So it's always we share our knowledge. Okay. So I had a nice time with you. Hope this video will be helpful to all of you. So rest of the thing I'll take as a mock in the other class. Okay. This is all
Thank you
mock.
very much.
And what I wanted to plan regarding GYNEC in GP is I'll go with topic wise so that I can just, if I am going into subfertility, I'll make you solve some 15-20 questions in which all the subfertility questions will be covered and I can give you that concept. And next topic will be antenatal care, where I can just give you basic questions on the antenatal or like GDM, hypertension, all those antenatal care. Next topic will be AUB. Like that, if we go topic wise, it will be better for us and our preparation will be more nice. Am I clear?
Yes,
I
ma'am.
know GP GYNEC is only like one part of the GP, but it is a scoring subject. You just know the basic things. You score like N out of N in OBG. That will help you in like even the other subjects are on the lesser side. You can just grab the marks over here. And believe me, OBG is so conceptual. Once you start like learning, you love it. But if you feel like it's a terror subject, it will be terror only. Seriously, I'm telling you. So don't buy hard, guys. Just go into concept. Ask me. I'll explain you everything in detail. Whatever it is, you can post in the group. I'm always there for you. Okay?
Yes, ma'am.
Yes.
Nice talking to you all. I think now it's a time. I'm just stopping the record. If you have any doubts, you can personally message me in the group.
Thank you, ma'am, for your kindness.
Thank you. Bye-bye.
Thank you,
Take
ma'am.
care.
Thank you.